So, first of all, thank you for being here. And we hope that you will really enjoy this occasion. And we expect a lot from you because this is a very special gathering of experts, a worldwide experiment, a global experiment. So I think, and I'm very grateful to Luciano Floridi for having helped the Fondazione Cini in being central in this event. Which are the expectations of Fondazione Cini? The mission of Fondazione Cini, that it is a fantastic island, is a center of arts, music, traditions, but we want to develop special dialogue in a period of the world history where, in my opinion, we are going to a very change in the historical evolution of the world. I think we are at the end of post-war period. And so we have a very special responsibility in finding a line of dialogue that can be useful for the humanity to keep an unbiased occasion of discussions, trying to live, when we speak about ethical approach, trying to have a common ground, projecting our society toward the future. The choice of artificial intelligence, as you can imagine, is super important. Artificial intelligence potentiality is enormous. Obviously, in some continents, as the case of Europe, there is more stress sometimes on a defensive approach than an offensive approach. I think to be more offensive, we need to create a common trust. And so the role also of this gathering is to create a language also based on an ethical and values approach to create more trust and more influence in the direction, of a positive direction, having AI for good and not for evil. So I'm totally convinced that then the application to health is especially important. And so we have three special words in our gathering. One is ethics, the second is global, and the third is health. Three very important words. And so I hope that working together, we can arrive to some kind of consensus. I think that we have a duty and responsibility to try to be influential. In which way has to be also discovered in this meeting. But I think that our duty is to not only to discuss about problems, but try to have problems influencing it and trying to get, I will not say solutions, but directions, which can influence all the body interested in the activity in this field. We have doctors, we have developers, we have designers of AI, and we have also regulation and all this kind of direction. So I think that your role is super important. Gathering here the most expert, I will say, from worldwide, we need to understand how we together can be really influential. The second issue, in my opinion, very important, we were stressing that, is the presence of young people and young students and young PhD working together. We need to have this kind of blend of different culture because the evolution of technology is so rapid that we need to understand also different generations, how they are approaching the same problem with a different kind of focus. So this is a general approach, and Fondazione Cini will follow with other issues that we consider important for the humanity. What it is important in this kind of organization? One is the way that we organize. Different is a symposium. Symposium is a remembering of some Socratic way to meet, in which is not everybody is ready and is open in an unbiased way to speak about problem without the issue to have an external and immediate people looking what we are saying. And second point, that we are putting you in an artistic environment. you will have a Vivaldi concert tonight. There is some sense in that. I'm totally convinced that doing this kind of thinking in a context of beauty, music, and art is creating a joint affiliation, a different way to approach the problem. So sharing the importance of arts also in defining and also changing our perspective when we touch this kind of problem which are highly technological and scientific. So I thank you very much. I hope that you will enjoy also the Vivaldi concert. We will have a final dinner in a room where you have Paolo Veronese and Palladio designing the room, and Paolo Veronese, very important painting. So we are really in a very special conditions. And so I hope that you all will enjoy. We make a big effort in organizing that, but because we think that the gathering of these brains, spirits, and will be very important for all our society. So we invest on that, but we invest together with you. So we think that you, in a certain way, are shareholders of this idea. So thank you very much for being here.
Thank you. Welcome back again. Well, thank you very much to Dr. Rocca for his introduction and spending some time with us. As you can tell, the day is packed. I don't know what took us. We thought we could do it, and no, we cram as much as possible within very few hours. There is a little change in the program, so pick up your pen and mark the following small change. We will skip the coffee break at 6 o'clock. That coffee break is not going to happen. Instead, we will go from the keynote and the respondent and the discussion straight into the panel, meaning that we can gain that half an hour and move everything a little bit earlier so that we have a bit of extra time to prepare for the special dinner. I know we are, or at least some of you are superhuman, but being in two places at the same time is not a good idea. Normally generates delays. So in order to avoid to rely on your superhuman sort of abilities, we thought we could give you at least half an hour to go back, change your tie, and come to the dinner. Which means that we will close also with my remarks a little bit earlier, around 6:45, and then we will get together at the meeting point. Instructions will follow, so don't worry, it's the same meeting point, but we will remind you. And from there on, we will be guided by our wonderful host, so we can stop and just be piloted for the rest of the evening. So just to remind you, there is no break. We go straight into the panel, and from there onwards, we just glide through, thanks to our host. It's going to be easy. You can't miss it, but we will repeat it, so don't worry. And with this out of the way, and I still look at some of you in need of some coffee, because they look at me as if I was speaking something really strange. We are almost there. So I would like to welcome here our first keynote. Angeliki, where are you? Welcome.
Hello. Nice.
Thank you for joining us.
No, thank you for
The floor is yours.
me. Thank you. Oof, I think that is my chair. It says keynote here. So I'm good. Good. You're going to? Yeah. Excellent. So first of all, I would like to thank Luciano and Jessica for inviting me here in this beautiful place. I've been enjoying the conference so far immensely, and the discussions we're having at the breaks as well. So it's a real pleasure and privilege, and I would like to thank the President as well for pointing the immense value of art and beauty when it comes to trying to kind of solve problems and find solutions, or at least pathways to solutions. And it reminded me of the Russian philosopher Berdyaev, who said that the beauty is going to save the world. And I think that we are, with the interdisciplinary kind of workshop and in this beautiful environment, we have like a good chance to make at least a start there. So yeah, thank you very much for that. So is this to change? Okay, so before I start, I'll just like to kind of clarify a couple of things, terminology, like philosophers would like to do those things. So one of the things I want to say that is the kind of the type of AI I'm going to be talking, when I talk about AI, the type of AI I will have in mind is the type of decision aid tools that we've been talking about yesterday and today. So I'm not going to talk about general AI or superintelligence, and I think the rest of my talk might make why I'm making that distinction quite important. And the second thing that I would like to kind of underline is that when I talk about health data, I mean data that are held by healthcare systems. So it's data generated when one goes to seek healthcare in a normal sense of the way, rather than health-related data that maybe your supermarket or your gym or another kind of body might hold on you. And this is kind of the outline of my talk today. I'm just going to talk about the deficit of trust. Then I'm going to talk about some kind of key concepts and what they mean. So like what is trust, what is trustworthiness, reliance, and reliability. I'm going to try to answer the question whether trust is relevant when we talk about AI tools. I'm going to draw from like a couple of empirical studies that I've myself also run recently. And then I'm going to talk about public trust in AI. What does this mean? What does it look like? And then I'm going to move to the kind of the elephant in the kind of universal room, which is like the public distrust. And then I'm going to close with some suggestions for ways forward rather than solutions. Great. So a couple of months ago, I'll just start with a little anecdote. I was at a conference in Oxford talking about trust, and then a researcher who was developing AI tools for healthcare came to me and said, well, you know, we're really doing our best here. We're developing like the best tools we can. They're working quite well. We can demonstrate that. We've kind of come a long way since the beginning of this kind of new AI spring, but still people don't want to use them. Like doctors, they really don't trust them. They don't want to use them. Like, what is going on? Like, we're trying our best, but this is not happening. So what is going on? Indeed. And this kind of like deficit of trust is not something new. Luciano and Jessica 5 years ago already were identifying this deficit of trust as being a fundamental barrier to the adoption of technology, and not just in the UK, but worldwide as well. So the issue of trust, or the lack thereof, has been one of the most persistent, I think, in ethics and policy and technology discussions around the development and implementation of AI tools in healthcare, as has been the attention on how to build and maintain trust in AI. So why is there so much attention on trust and fear around the absence of trust? The explanation in some way might seem quite straightforward, as that when we trust, we don't feel the need to keep the other person or the other actor in check. We know or believe that they will do what is expected of them, and this attitude creates an open space. So when we trust, things become easy, become effortless, become frictionless. This is what social scientists and social theorists, mean when they talk about trust as a form of social capital. So when we trust, we can move on even when things are uncertain, even in the place of uncertainty. But when we distrust, then we're looking for assurances, and that things will go our way, and then what we do is we put barriers and we introduce checks and balances to ensure that we will not be let down, we will not be disappointed, and more aptly, we will not be betrayed. So if trust is capital, then it makes sense that companies that operate in this space want to be trusted, and they want to be seen as being trustworthy. So lack of trust slows things down, it says. Like the same way that rules and regulations that can be introduced as a response to trust can hamper innovation, or this is what we usually say, and we discussed a bit yesterday about how this is like a narrative rather than necessarily a reality. And they make things kind of more costly as well. So this is what like a lot of the companies would say. So trust is efficient and effective. And it's like the AI promised to be. Like AI promises to be efficient and effective, and trust also is efficient and effective. So in recent years, there's been a lot of focus. There's been a lot of focus on how to secure and engender trust in AI. So there's been a proliferation of ethics principles and guidelines and recommendations. Again, we talked about this yesterday. So the civil society group Algorithmic Watch, before it stopped counting, like earlier this year, it had amassed around 170 of such documents coming from different stakeholders, from academia, from industry, from governments, from supranational organizations like the EU. A systematic review published last year kind of included 200 of these documents. And although this in itself can sound confusing and overwhelming, and Ravi yesterday said about like it feels like drinking from a hose pipe, studies like Effie's, and it's a shame that she wasn't here yesterday, we missed her talk, show that there is a convergence among all these kind of documents about the ethical principles most important in AI, which they seem to kind of all coalesce on transparency, justice, non-maleficence, responsibility, and privacy. So alongside these kind of rules and regulations or recommendations and principles, what we also see is a development of technological solutions to the issue of trust. So technological approaches or design approaches like ethics by design, compliance by design, or even trust by design have emerged in recent years too. And the one of the most kind of famous, or the one kind of widely used, like the AI one, the EU ethics by design principles and framework that now all projects funded by EU need to kind of comply by. So the main idea behind these approaches is that principles like safety and security and justice and explainability should not stay as external parameters against which we judge the technology, but rather we need to design, develop, and implement the technology by having these principles as the roadmap. And we need to embed them into the code and the system and the processes. So the idea is that we achieve privacy by design, and we achieve explainability by design, and justice by design, rather than asking these technologies to adapt to these ethical principles a posteriori. So, of course, this approach has its own problems. For example, one will ask you, like, whose conception of justice should we build into these AI tools? And how do we know that designers can actually take these abstract principles and turn them into something that is tangible within kind of a product and develop what we might call like an ethical product? And there is also this feeling that maybe by kind of promoting these kind of technological solutions to the problem of trust, like we kind of send the message that once you design your tools with ethics in mind, whatever this might mean, then this is job done. Like you don't have to worry about ethics or trust anymore. But I like to put these criticisms aside for a moment here, and to kind of draw the attention to the fact that what this attention to build and maintain trust demonstrates is that there is a real desire, I think, out there to be, but also be perceived as being trustworthy. However, and this is the caveat here, and this is what the kind of that researcher at Oxford was telling me, it's like, we're doing all those things, but still we're failing, and we kind of seem to be failing quite substantially. So trust in AI is falling, and it's falling worldwide. And I'm drawing these figures from the latest Edelman Trust Barometer report that shows, as I said, like trust in AI is falling worldwide. So globally, trust in AI companies has dropped to 53%, down from 61 5 years ago. And it seems to be falling faster in developed countries than in the developing world, which I think also is quite important, because you would think that the kind of developed country, in the developed countries, people have much more exposure to this technology rather than the developing world, but it seems to be having the opposite effect. So in the US, trust has dropped by 15 percentage points over the same period, and that's the index where it shows that the developed countries are kind of leading on trust at the moment, and also that the tech companies used to be one of the trusted sector in at least 90% of the countries that the Edelman will include in their study, but today they only are kind of account for about half of the countries that they are including. So like the tech industry itself seems to be losing trust around like the products that they're developing. So what is going on indeed? And why, whilst AI is getting better and better, people are less willing to trust it? So I think that to answer this question, I would like to go back a bit to kind of some basics and ask the question, what is actually trust and what is trustworthiness? And that might help us clarify what's going on. So when we talk about trust, in this context, we talk about what I call specific trust. This is where person A trusts B, person B to X. A does not trust B in general, but only in relation to a specific action. This is what I mean by specific, right? So the trust is to do a specific task. Trust is based on two things. First, a belief or expectation that the other person has the skill, the ability, the knowledge, etc., to fulfill the entrusted action. And second, and this kind of second element is quite crucial, I think, the person also has goodwill towards the trustor, so has goodwill towards the person who's trusting. I follow Bayer's terminology here, talking about goodwill. Jones also uses the same terminology, but other theorists in this field kind of talk about commitment, like Holly. I don't think that this is quite important here to kind of talk about whether it's goodwill or commitment or something else. But what is important is to see trust as a relational attitude that involves reliance plus an extra kind of moral factor, like a moral element into it. So trust is an attitude, a way of positioning oneself in relation to another person. So John trusts Mary to help him cross the road. Trustworthiness, on the other hand, is a quality or a characteristic or a virtue, or however you want to call it, of a person. So Mary is or is not trustworthy. So one would hope that if John trusts Mary to help him cross the road, he's basing his trust on some good reasons. That, for example, John has a good reason to believe that Mary has good sight and good hearing and she's able to navigate the traffic, and also that she cares about him and she's not going to kind of push him under a bus as they're trying to cross the road, and that she will make sure that he reaches the other side safe. So is the fact that John trusts Mary an indication of Mary's trustworthiness? Well, yes and no in some way. So we hope that we're good judges of people and that we're able to place our trust appropriately. But of course, the fact that we trust someone does not make them necessarily trustworthy, right? It just indicates our belief about this person or this actor. Although, as I said, we all hope that we trust the trustworthy and distrust the untrustworthy, this is not always and necessarily the case, as anyone who had their trust betrayed knows. Sometimes we trust the untrustworthy and we show distrust towards the trustworthy, and that can be quite problematic, as O'Neill kind of notes when she talks about the value of trust. So, like trustworthiness is also context-specific. So one person or one actor can be seen, can be trustworthy in one context in relation to one specific task or activity, but not in another. So Mary might be trustworthy in relation to helping John cross the road, but not with looking after Gina's dog, for example. So I hope that this is clear about what trust is, what are the the conditions of trust, and how it connects, but also differs from trustworthiness as a concept. And I would like to introduce or to talk a bit another term here that is also relevant, and that is the term of reliance. So in my definition of trust, I've already talked about reliance when I said that trust is reliance plus something else, this kind of other factor, the goodwill or commitment that we have towards the person who's trusting us. So trust and reliance are very similar attitudes, but also differ in significant ways. Reliance is an act of dependence based on the likely prediction of an actor's behavior. It does not require or entail assumption of goodwill. We rely when we know or believe that the other actor, the other person, has the ability to do what we want them to do, And we also believe that they have enough self-oriented reasons to do it. What I mean by this is that they will act as expected, not because the will are good, but because not acting that way will be costly for them. So we rely on our bank to keep our money safe and pay us interest, for example, when it does. Not because we believe that our bank really likes us and really wills our good, but because they want our custom. And because if they don't do what we expect them to do, then there are laws in place to protect us and hopefully punish them. So it is in their interest to do what we expect them to do. So reliability, like trustworthiness, is a characteristic of the actor that behaves in this particular way. So the moral difference between trust and reliance is that trust entails a position of vulnerability for the person who trusts, as they have no other way to ensure that their trust is heeded other than hoping that the other person really wills their good. That's why when we have our trust broken, we don't just feel annoyed, we also feel betrayed. But with reliance, I think it's different. Yet, yes, things can go wrong and others can fail to do what we expect them to do, and we feel very annoyed by it and very angry sometimes as well, but we don't feel betrayed because we don't have the same expectation that the other person thinks of us in some kind of particular way before they decide how to act. So with these kind of things in mind, I would like to and thank you for bearing with me as we're going through this kind of conceptual analysis, I would like to go back to the question of trust in AI. So given what we know about trust and reliance and trustworthiness, we decided to go out and explore these trust-related attitudes of end users. In this particular study was doctor and patients with respect to AI tools. So with my colleague Rachel, we ran a study alongside the project that was developing a decision aid tool for perinatal care. And we interviewed healthcare professionals, but also pregnant women and birthing parents about their perceptions of trust in AI and the impact that it might have in the care delivery and also their ability to make clinically relevant decisions. So parents, and what we find was quite interesting. So parents talked about the importance of using what they called reliable data to develop AI tools. And here are some quotes that I like to use. So one person said, obviously, I'd want to know where's this data from? Is it reliable? And for them, reliability really meant AI tools that work well. So AI is only good as its inputs. I think it would have to be based on a wide breadth of inputs and experiences for it to have proper and unbiased outcomes. And this idea of biases and how AI could, if not done properly, exacerbate health inequalities was very much part of their reasoning. So another one said, I have some of the same concerns that I was talking about already around how do we make sure that it's not a biased data set. It comes up on stuff about maternal outcomes for Black and ethnic minority women and the fact that data will be in the system in the way it is currently. And making decisions that are good for the majority of people often doesn't work for the people who are already in a significantly marginalized position. And I think this is like a point that Jess also made yesterday about how biases are in the data and upon which we are training these AI models. And they felt that it would be difficult to counter potential biases in the system if models are not explainable. So if you don't know on what data sets the model has been trained on and cannot ascertain why the model is making a certain prediction and the level of accuracy associated with particular prediction, so like all these kind of false positives, false negatives. I'm not going to talk more about that because probably I'm saying the wrong thing. And for them, it was like very, in particular with kind of the Black and ethnic minority mothers that we know that are having far worse health outcomes in the kind of perinatal context. So for them, it was like impossible in the absence of all the certainties to know that they can rely on these tools for their care. So what we see is that patients, and in this case it was pregnant women and birthing parents, have a quite, I would say, kind of sophisticated understanding of how AI might work in the healthcare setting. And for them, what matters is whether AI models can do the work that they are supposed to do. So in this way, when they're thinking about, can I depend on this tool, they're thinking of this dependency in terms of reliance, I would argue, rather than in terms of trust. They want to know that the tools work, but they're not concerned with questions that might relate to this kind of extra factor that I was talking about that trust requires. They're not talking about whether AI will their good or is committed to them in some particular way They just want to know that it does what it says on the box. And doctors also are talking about AI in terms of reliability, AI tools in terms of reliability. But they kind of take this one step further. They don't only want to know how that it works, they also want to know how it works. So I think they're really holding on to this idea of them being like the experts in the room. So like medical expertise kind of still lies with them. So how AI is developed, so they can then want to know this, so they can be assured that they can depend on it for their clinical decision making. And here is a quote from one of our participants. Not who, it's that the what process, what ethics, what cohort, what population size, how is it conducted. So it's more around the how transferable is it, how robust is it basically. The why, it's the how did you get the results that you got and how valid they are. So for healthcare professionals, understanding the research and the development process is what enables them to have confidence in the technology and consider it reliable. Moreover, transparency in these processes reveals to healthcare professionals whether and how it is appropriate to integrate the system into their clinical decision-making, because they can compare the research context to their own clinical setting and to the patients that they see. And they want to know about how the tools are validated, what is the processes, who approves them, on what grounds, etc. So what we see is that end users, and in this case patients and doctors, when they're talking about AI tools, they talk about it in terms of reliance rather than in terms of trust. And to me, this seems to be quite reasonable and appropriate, because I think that AI tools are just that, they're tools. All we need to know about tools is whether we can use them to do the job that they're supposed to do well. If they can help us with a task, and if they do that well, then people will use them and people will rely on them. If not, then people will not. So we don't need to have some kind of complicated ontological theory when we talk about AI tools, that we need to think of them as kind of moral agents in some kind of higher level that deserve our trust. So far, so easy theoretically, I would say, but you would possibly kind of want to come back and say, well, but if we go back to what the researcher was telling me in that anecdote earlier, like, well, they are developing reliable tools, but people are still not using them. So, like, why is this kind of reliability not translating into usability, into acceptance on the ground? So I would like to turn now to a different kind of trust to see if this could give us some insights, some useful insights. So, and this is like public trust. So public trust is the trust that publics hold towards institutions tasked with serving the public good. So the main condition of trust is convergence of interest between the public and the institutions. The public wants to have their good served, and the public institutions is committed to serving the public good. So the legal system is committed to serving justice fairly, police to protecting all citizens, healthcare systems, for example, the NHS, which is like one provider, one buyer, is like to provide healthcare to all at the point of need. Of course, I should say here that the fact that public institutions warrant trust on the basis that they are there to serve the public good does not mean that they always and unequivocally ought to be trusted, or they always deserve public trust. I'm not the one advocating for blind trust here. When public institutions do not do the job they're supposed to do well, then they lose public trust, and I think that is absolutely fair. But what I'm saying is that trust is relevant and appropriate way of relating to them because of their public aim. Whereas other institutions that operate in this space do not have a public aim, like private companies or non-public institutions, do not warrant public trust. We might still depend on them or to provide certain services, but the basis of our dependency should not be trust. It should be, or can be, reliance, for example, which means that we can have an instrumental relationship with them or a contract-based relationship with them, but not one based on trust. So for the public, who is developing AI tools, who has access to their data to develop these AI tools, and why matters to them. Over the years, they have expressed their distrust towards, for example, the sharing of their data with private companies. I think, again, Jess alluded to that yesterday, for the development of AI tools, amongst other things. So if the aim is profit-making rather than serving the public good, this seems to matter to them. And this is, again, a quote from our study. You want to know that it's not just someone trying to make money. You'd want it to be something independent, where you're like, is this people who are trying to make money, or is this people who are trying to make better outcomes for women in labor? That would definitely mean something. So this distrust towards the use, the involvement of private companies that have like a profit motive to the developing of AI tools, I don't think it's unique to this case about perinatal care, nor it is unique to the UK. As I said, many studies have demonstrated that the public distrust for profit companies that operate in the healthcare space. Also, the public has been voicing again and again the distrust towards public institutions that seem to promote for-profit companies' interest rather than the interest of the public. But also they have expressing the distrust toward public institutions' ability and commitment to serve the public good. So again, I'm just going to bring a quick example from the UK that, again, was mentioned yesterday. Like now it's the infamous care.data case, where the idea was that they were going to bring together social care and like all the healthcare data in order to help provide better care to patients, but also for research and innovation. And the research and innovation was also going to happen with outside the the public system, and that led to more than 1 million people opting out of the system, and the system was the plan was discontinued. And then it was followed by a different plan, the GDPR, that was also had exactly the same problem, and that was discontinued, and then. And that stopped, and more recently, like another scandal that has erupted around this thing in the UK is with a contract that the NHS has awarded to Palantir recently, and is a contract for Palantir, which is to develop the NHS data management platform called Federated Data Platform, which is going again provide this joint service for the NHS. But Palantir is a tech company specializing in also AI-powered military and surveillance technologies, and that has raised issues of public trust. And I'm just going to give you like a very quick quote from a paper that was published in the BMJ, where it says, if NHS England is to recover its own reputation and maintain public trust in health data systems, it must cancel the contract with Palantir. And this is just for me to show that the distrust does not just go towards the company, right, it does what it does, and this is what, they're not hiding what they're doing, but this also goes towards the public institution, who supposedly is there to protect the public good, but this is not seen. So what this demonstrates is a change in direction in healthcare. So healthcare systems not only need to now, it seems to support the health of a nation, but also they need to support the wealth of the nation. So we're seeing this development of the health and wealth agenda going hand in hand. And citizens are not just service users, but also they are data subjects. And this changing landscape is bringing new actors into the mix that they were never here before. So we now have global tech companies taking prominent role in the healthcare space, not only as developers of health technologies like AI, but also as providers of what we can call now the new bricks and mortar of the digitized healthcare. So the word of infrastructure is probably the word of the day yet again. So these are the two red lines that I said, the use of health data for profit and failure to protect or serve the public good, seem to be the two red lines that the public seems to be voicing again and again, but they're not quite heeded. So what can we do about this distrust? How can we address it in a way that will not just leave it there to fester, to use this terminology here, and become bigger and even more entrenched? So, and this is just to remind you that this is not just a UK problem, right? That we see that was the graph that I had earlier, that this is happening generally. So what I would like to suggest is that maybe we need to change our attitude towards distrust. And that might look like a bit of a radical view. So bear with me. I like to hear your views on that. So maybe I would like to suggest that distrust is not necessarily a bad thing. It's not necessarily a problem that we need to solve. So here, what I would like to propose that is, instead of treating distrust as some social malady, something that this disease that we need to correct or avoid, I would suggest that maybe what we should do is kind of the opposite. I suggest that maybe we should lean into this public distrust and properly engage with it. So distrust, or some forms of distrust at least, not generalized distrust, but some forms of distrust, are fundamental in democratic societies. Here, instead of a problem or a pathology, distrust is conceived as a sign of an engaged and politically active society. Although generalized distrust is detrimental to the normal functioning of democracies and societies, attitudes like lack of trust, attitudes that are linked to lack of trust, like vigilance, demand for an exercise of oversight, suspension or withdrawal of cooperation, can be seen as beneficial in keeping power in check and ensuring that common good is served. So viewed this way, distrust becomes less of an obstacle to social capital and more of a power to drive action and bring about positive change. So in order for this change, however, to be positive, distrust needs to be taken seriously, as ignoring distrust could make it fester and lead to spillover and generalization of distrust in society with detrimental consequences for the flourishing. But here is the problem. Distrust in science in general and in health data research and innovation in particular, and in AI, and here I include in AI, is often perceived as a predominantly epistemic issue, like a knowledge deficit problem. So the main assumption here is that rejection of new research initiatives and technologies is driven by the public's fundamental failure to understand what experts in the field know to be true. So the obvious and simple solution to the problem is to educate the public. So once the public understands and accepts the expert's truth, then they would trust and hence use these new technologies that is presented to them, and everybody will be happy. So the knowledge deficit problem was first developed in the mid-90s. It's not a new idea, and has been a kind of a dominant paradigm in science communication and in science policy ever since. And it has led to the kind of this model, the public understanding of science, research and policy field, and to the development of a lot of tools and theoretical approaches that try to kind of promote it. However, studies have demonstrated that trying to educate people or make them revise their held beliefs, particularly when distrust is present, think of the anti-vaxxer movement here, does not really go very well and does not necessarily lead to more trust. This is because when we choose whom to trust or distrust, and subsequently how to translate our trust into action, epistemic considerations are only one type of considerations that guide our decision. Values, things that we hold as being fundamental and important, but also emotions, can play an equally or even more significant role in forming trust or distrust attitudes. So more recently, different models of relating between publics and science have emerged, arguing for the centrality of values in science and calling for value alignment between publics and science. And these models, based on the paradigm of engagement and involvement and co-production, I think, again, Amelia was talking about this idea of co-production, rather than education, so let me tell you, are seeking to advance or counterbalance and maybe even replace this public understanding of science model. Yet, and despite these efforts, the lure of the knowledge deficit model can persist, especially in the science policy sphere. And I think there are a number of reasons that can explain the tendency for science policy to hold on to the deficit model. I think, firstly, it presents a very simple and thus very attractive reading of the problem that coheres with certain widely held, albeit criticized views about the objectivity and the value neutrality of science and technology. So, and I'm thinking of Jasonov here. Secondly, the presentation of the distrust as simply an epistemic problem or like a knowledge-related problem lends itself to an equally simple kind of solution, which is education of the uneducated, of the illiterate public. So this simplistic formulation of problem solution can be particularly attractive to science experts and to policymakers seeking to address issues of distrust. Thirdly, framing the issue as an epistemic one does not require an examination or disruption of the context within which the problem presents itself, as the solution, education, can easily fit within this existing frame of reference. So to give an example, when the public says, I don't want to trust the involvement of the private sector in research and innovation that uses my data, my health data, the answer is not, okay, like what people answer is like, okay, it's not like, let's see how we can pursue research and innovation in a different way. It usually say, like, let me explain to you again why we need to do things this way. So it's kind of, it's a different positioning to what the other person says. So, but what I would like to suggest as a different way forward is that we need to take distrust seriously and actively listen to it. So like some active listening from the side of the policymakers, but also the researchers might be what was needed here. So taking distrust seriously, however, would need to, so it's not getting people in the room, validating their feelings in a very nice way. Yes, you're absolutely right, and pat them in the head and send them on the way, and then do what we were going to do anyway, which seems to be a lot of the kind of public engagement exercises at the moment. I think that, like, if we are to take distrust seriously, then we will need to commit ourselves to two things. One is to pay attention to all or the plurality of reasons that might drive distrust. So we need to there include epistemic reasons, and I'm not saying that there are no epistemic reasons that might be driving distrust. I'm not saying that there might not be people out there who do not understand certain things, and this is why that they distrust them. But there might be, as I said, value-based and affective reasons, and this also need to be taken into account seriously. And the second is that it requires to kind of create the possibility to imagine and explore solutions outside the frame of reference that yields distrust. Because if we forever stay within the frame of reference that the publics seem to be rejecting and saying, like, there is nothing we can do about this, then we will not be able to address public distrust. So, and that's my summary, so I think I'm good on time. So my summary is like, so what I've argued today is that distrust is important for the development and acceptability of AI. AI tools, however, the tools, not the context of the system that builds AI, but the tools themselves do not need to be trusted, but they need to be reliable. So I think that can be a direction for regulation when it comes to that. Trust is warranted towards companies and institutions developing and regulating AI, health data, and research and innovation. Public trust is warranted towards public institutions because of their public aim. The red lines of public trust in AI and health data research and innovation more broadly is the use of health data for profit and failure to protect and promote public good. So who is having access to our data, who is developing the tools, for what reason and why is relevant and is important, and how institutions that warrant public trust behave in this landscape matters too for public trust. So over and over again, the public has expressed these red lines when it comes to the use and the development and innovation in this space. But there's been like a lack of response on the other side that this distrust is taken seriously. So far we've been trying to deal with distrust by viewing it as an epistemic problem and trying to explain it away. Like this, if we tell people that this is that everything is going to be fine, then they will accept it, or we tell them that we know better, then that they will accept it. But this hasn't worked so far, given that trust in AI is falling worldwide. So my suggestion is different. I suggest that we should approach distrust as something of value and engage with it by really listening to it and using it as a catalyst for change. I suggest that taking distrust seriously would commit us to these two things: to pay attention to the reasons that drive distrust, and try to come up with, allow the possibility to imagine and explore solutions that might sit outside the frame of reference that exists in the current status quo. So yeah, thank you very much for your attention, and that's the end of my presentation.
Welcome back. And good morning again. We can now start the second half of the morning. Just a reminder, just in case, if you are like me, you need an extra coffee. There will be no coffee break at 6 p.m. We are skipping the coffee break to go straight into the panel, so that we may have a little bit of extra time to get ready for the concert and the gala dinner. I've also been told to remind the gentlemen, at least. The ladies do not need any reminder, but the gentlemen are reminded is business casual. I said business casual. So that's the dress code for the concert and for the gala dinner. Now, we can move straight into our next round of contentful discussions. We had, as you can tell, a lively interaction on trust. It is time to talk about social determinants. Elaine, the floor is yours. Thank you. And I shall call the respondent afterwards. Thank you.
Good morning, everyone. So I'm going to talk to you today about the social determinants of health. Here are some of the things I'm going to focus on. I always like to start with definitions just to make sure we're all on the same page. And then I'm going to talk about the use of AI for social determinants of health. And then lastly, I'm going to talk about neighborhood and the built environment, which is what my work focuses on. So you might have heard the saying that where you live determines your life expectancy, or how long you will live, more than your genetics. And in Boston, where I work, there are neighborhoods that have life expectancy with differences as large as 30 years. So if you move from Back Bay to Roxbury, those two neighborhoods are about 3 miles apart. And they have, in Back Bay, the life expectancy is about 92 years. And in Roxbury, it's about 59 years. And when you walk through these neighborhoods, you can see that there are very physical differences in the houses, in how the streets look. When you start looking at other factors like income and education, you can see the very significant differences between these neighborhoods. These are all factors that predict or shape our health outcomes. So the WHO defines the social determinants of health as the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development agendas, social norms, social policies, and political systems. So almost everything shapes our health outcomes. Social determinants of health are a major cause of health disparities because some groups and individuals experience circumstances or have barriers and other factors that keep them from experiencing optimal health. And so addressing social determinants of health is very important for advancing health equity. Here are some of the social determinants of health that are highlighted by Healthy People 2020, so things like education access and quality, healthcare access and quality, neighborhood and built environment, social and community context, economic stability, and so forth. One of my colleagues ran a survey a few years ago that basically asked people in 8 different countries what they thought were the most important determinants of good health. And as you can see from this plot, there was a very consistent agreement that healthcare was important, or at least people think healthcare is one of the most important factors. And then you see other factors like education also coming up in some countries, and there's some differences in how the other factors are ranked. Things like genetics had almost consistent agreement in terms of percentage of people that rank genetics as being important as an important determinant of good health. The interesting thing is that when the same survey respondents were asked about what policymakers considered to be the most important determinant of health, their answers changed. Politics was the most significant one in terms of change between the two responses. So people think that policymakers actually think that politics is one of the most important social determinants of health. In public health, there is agreement that when we look at the different factors that shape health, the social factors and social and behavioral factors have about 80% impact on our health outcomes, and healthcare is about 20%. I think AI can impact how we derive and study social determinants to advance health equity, but I also think it's important for us to talk about how AI is shaping social determinants of health. And I'm just going to give a few examples, and I'm sure you can think about a lot more. And yesterday, Emilia talked about how AI is shaping political outcomes and how it's impacting political outcomes and the environment, which are all factors that impact our health. And in this particular example, the first one is around people who label data that's being used to train AI systems and how that impacts their mental health. And also, most of these individuals are coming from low and middle income countries and also have poor working conditions. In the middle, I talk about or write about how AI can be used in matching systems or for resource distribution, and this can be good or bad because it determines who qualifies for a job, who is matched towards school, who is recommended for additional resources at hospitals, and so forth. And the last column, I left that for you, so you can fill out some of the things that you can think about in how AI is impacting social determinants of health. So in this talk, I'm going to touch on the last three social determinants of health. I'll talk a little bit about education, but just specifically to give an example of work that's been done in Africa. So in the for healthcare access and quality, there's been a lot of conversation around telehealth and how AI can be useful in that space. And especially during the pandemic, how that was a means for different people to get access to healthcare. But there's also been studies that have shown that there were disparities in who actually was able to use telehealth, because that requires you have access to certain resources to be able to use it. The papers that talk about the triage of patients to better manage limited resources, especially during COVID as well. And I think this is also useful for disease epidemics, not just COVID, so even seasonal infectious diseases that we see, how this can be useful when we think about better managing clinical resources. Disease diagnosis in limited resource settings is another one that I hear a lot, and how AI can be useful in that space, whether it's to diagnose malaria or other conditions where there are limited resources. But a lot of the work that I have seen coming in for that particular topic is using data that is clean and perfect. You know, it's already been labeled pretty well and the data looks clean. But when you actually go to those clinical settings, the data can be so messy that the algorithms that have been trained using this perfect data does not actually work very well. So I have colleagues in Uganda who are working to create algorithms that take into account what happens in the clinical settings by creating some of this messy data and then trying to use that to train AI algorithms and see how well they work in disease diagnosis. Improving predictions of patients' risk for diseases. In this particular case, there's been quite a few studies that have shown that when you incorporate social determinants of health into models for predicting risk, those models tend to do much better than when you don't have social determinants of health. Democratizing of quality medical information is another one, especially for countries with limited resources, where people talk about developing things like chatbots so that individuals can have access to medical information more easily. And then there's also discussions around bias reduction in clinical interactions, and this is mostly focused on sensitive topics, so mental health topics or stigmatized health conditions like HIV care. And I have colleagues who are developing chatbots specifically to encourage people to talk more about these conditions. And there have actually been studies showing that people sometimes are more comfortable sharing information with chatbots than they are with clinicians. So social determinants of health needs within the clinical context, there's also quite a few opportunities where AI can be useful. So specifically, large language models have been shown to improve identification of social determinants of health from electronic health records data. There's also been usefulness in terms of detecting changes in patients' social determinants of health needs. So if someone is currently has housing, but then is at risk of becoming houseless, that's something that could be detected. It can suggest ways to mitigate bias in clinical notes. I know we know AI algorithms and bias, but they can also identify bias. So if you give them a clinical note and say, can you identify bias in this, that's something they can do. Chatbots can provide simple explanation of how to access resources. So when a patient comes to a hospital and is interacting with, or maybe goes to a website and trying to learn more about a particular resource that has been recommended, this is one way that it can be used, chatbots can be used to better explain information to patients. And relating to that, researchers have demonstrated that LLMs can be useful in recommending social services or making referrals to patients who have needs. However, effective applications within and outside the healthcare systems, I think, require co-designing with relevant communities. It requires intentionally designing to address health disparities or advancing health equity and creating access to digital resources. So to talk a little bit more about co-designing with communities, I believe that those with the problems are the experts of their problems, and they know what will work for them. So they might not have the technical expertise, but they know if you bring a tool to them, they know whether they understand that tool enough or they feel comfortable enough using that tool or not. And social determinants of health screening requires people to reveal sensitive information about themselves. So this also goes back to trust, like people need to trust whoever is asking them for that information. And we know in different contexts, there's been historical factors that have shaped how people trust clinicians or trust medical institutions. So that's something that's very important to think about. Community buy-in also increases the chances of success. So whatever tool is developed, if community have buy-in into that tool, if they're involved in the process from the beginning, there's a higher likelihood that that tool will perform well and would be sustainable in the long term. And there's also very, very important that whatever tools are developed are tested in clinical settings, because it's very easy to build things on computers that do really well, but then when you actually take it out into the real world, it doesn't really perform as you expect. And I'm going to give you a few examples. I don't think AI can decolonize healthcare in Africa, but in this particular essay, the argument I was trying to make was the need to allow Africans to develop their own solutions, rather than having people in the West develop solutions and then take them to Africa and expect Africans to adopt them. And in this particular essay, I used Data Science Africa as an example. So Data Science Africa is an organization that was started in 2015 in response to the need for data science capacity across the continent. And so what we do is we have data science training every year. We go to a city, and we have to be invited to that city, so we don't just show up to a city and say we're going to have an event. So someone in that city at a local institution has to invite Data Science Africa to come, and they co-host the event with us. And so we'll go there, and for 3 days we'll have data science training, and then 2 days we'll have a workshop where we invite researchers across the continent to come and present their research and findings. So this year, the last one was in Nyeri, Kenya, and we had talks from applications of AI in health to developing models for African languages. We had talks about animal conservation. It was a very broad range of topics that people covered at the conference. And so for this particular op-ed, I used 2 examples to talk about how systems, AI systems, can be co-designed with communities. So one of them is AirCo, which comes out of Uganda, and it was developed in Kampala, and it focuses on measuring air quality. And so the way the system was developed, it was co-designed with, or it was a participatory system where communities were invited to have conversations with the designers to talk about the need for measuring air quality and air pollution in the city. They also had mechanics as ambassadors, so they could actually spread information about the importance of air quality in Kampala. They worked with motorcycle taxi drivers and so they attach sensors to those motorcycles, and they ride around the city measuring, collecting data on air quality. So there was a lot of community engagement and a lot of community participation. And this particular program has now spread to more than 6 African cities where it's been implemented to collect data on air quality. A second example that I talked about in this op-ed is one that is focused on education. So this is a system that was developed in Arusha, Tanzania, and the goal is to predict when a student is likely to drop out of school. And this is very important, especially for girls, because the dropout rate for girls is a lot higher than for boys. And so it used this machine learning system, used very simple machine learning models, and collected data on several different variables. But they worked with teachers and they worked with parents to get input about the usability of the system, and were able to refine the system before it was deployed based on the input that they received. So going back to digital determinants of health, or the importance of having digital inclusion, there's been a lot of conversation around digital inclusion as a social determinant of health, given how everything is becoming digital these days. And there's so many different factors to think about, things like ease of use, usefulness, interactivity, digital literacy. These are all very important factors as we develop digital or AI systems for different populations. And when we think about digital inclusion, a lot of people tend to think about, other parts of the world and not so much places like the US. But there's data that shows that 15 to 24% of Americans lack any sort of broadband connection to the internet with which to use mobile health technology. So we can develop telehealth resources, we can develop a lot of mobile tools, but the populations that most need these tools don't even have the internet to be able to access these tools. So now I'm going to go into neighborhoods and built environment with a focus on cities. And I'm going to talk about some of the work that we've done in this area and how we've been thinking about using AI for measuring social determinants of health, specifically focused on the neighborhood. So historically, data on neighborhoods has been collected through things like surveys, census, administrative records. And these are all wonderful data sets because they provide very valuable insights. But the process of measuring neighborhood futures can be costly and time-consuming and can be subject to human bias. And so what we've been doing is trying to think about how can we use AI to develop more consistent measures around the built environment. And we found that some of the studies that have used different methods in the past and sometimes inconsistent in what the measures. So different definitions of the different indicators in the neighborhood that people are interested in can lead to different findings, and so comparing different studies is not always easy. So my work for the last 12 years has focused on looking at these types of data sets. So I started in infectious diseases. Initially, it was how do we use these different data sets to develop better infectious disease surveillance systems, and now it's how do we use data sets to measure social determinants of health. And so I look at things like social media, satellite images, street view images, and mobile phone data. In terms of social media, we've done work both in the US and in Africa. And some of that work was during the pandemic, where we looked at how people talked about healthy food, fast foods, and alcohol use. And in Africa, we've looked specifically at different factors that are associated with obesity. And we've developed models using search data, and we've also developed tools using image data from places like Instagram. And the goal for the particular study that we did in Kenya was to look at, so we did one study where we looked at the entire continent, and then we did another study where we looked specifically at Kenya. And the goal of that was to see how discussions of foods was changing among young people, whether as African cities as Africa becomes more urbanized, there is changes in how people talk, how people eat, what people eat, and how people talk about food. And we wanted to see how much that has changed over time. So the initial goal was just to collect data and see what that data looks like in terms of what kinds of foods people talk about and what was the calories associated with those different types of foods. Image data is one that I think is so rich and can be useful in so many different ways. In this picture, you see Mumbai. You see two different neighborhoods in Mumbai, and you can see how different they are and think about what are these different indicators and different things that you see on the screen, how that can impact health for different groups. And this is not just in Mumbai. There's so many different cities across the world, and there's so many disparities when you look at the neighborhood level. So this is Santa Fe, Mexico City. My colleagues at the Distributed AI Research Institute are looking at image data to measure the legacy of spatial apartheid in South Africa. And so this specific project is trying to look at how apartheid shaped neighborhoods in South Africa and how that continues to impact access to resources, specifically health, education, the environmental resources, and also how that is impacting racial equity in South Africa. This is another project that is based in Africa, and it's distributed across several different countries and cities. And the goal of this project, Urban Better, is to empower young people to think about their neighborhoods and think about disparities in neighborhood resources, and then advocate for change. And so they have an app that's available on the App Store, And when you go to the app, you can see images that have actually been collected across different cities and tagged for specific features, which I think is perfect for machine learning applications. So one of the studies we did many years ago was to look at the use of satellite imagery and obesity prevalence in cities. And so the broader idea for these studies is to think about the impact of policy on the built environment. So if a city or multiple cities say we want to make green space more accessible to neighborhoods in different cities, or in our city, can we measure how that differs across different neighborhoods? Can we measure whether the policy has been implemented in the same way or whether there are disparities, and how does this link to health outcomes? So for this particular study, we started off by just looking at whether convolutional neural networks can be useful in extracting information from the built environment, and then using that information to estimate obesity prevalence in the US. We looked at 6 different cities that had different obesity prevalence and also had different characteristics in terms of the neighborhoods. We also compared this to other data sets, so things like points of interest data, income, per capita income, and the data that we got was from Google. To our surprise, and to many people's surprise, we're able to predict obesity prevalence across different cities at a very high rate. So on one side, you have the actual obesity prevalence, and then the other side, you have estimates of obesity prevalence simply by looking at satellite imageries of those neighborhoods. Initial study didn't look at specific features of the built environment, but when we went back and looked at the images to see what parts of the images were being activated, a lot of it was green space, but there was also additional information that was being captured that was making our models be very predictive of obesity prevalence. Another study that we published last year focused more on street view images. So it's the same idea, but instead of looking at one specific health outcomes, we looked at multiple health outcomes, and we looked at very specific indicators in neighborhoods. And we worked with a collaborator who's been collecting a lot of data on neighborhoods, so they had about 160 million images that they had collected for cities across the US. And these images had things like green space, crosswalk, SFH is non-single family home, and other indicators of the neighborhood, like dilapidated buildings. And I'm going to show you a little bit more about that. And we looked at data for 59,000 urban census tracts, and this is where they're located across the US. And we started off by asking 2 questions. So one, can we quantify racial and ethnic disparities in built environment resources, specifically at the neighborhood level? So if we looked at different neighborhoods that had different racial and ethnic compositions, can we quantify what the disparities look like across those different neighborhoods? And the second question we asked was, how can we quantify how the built environment mediates the association between neighborhood racial composition and health outcomes? And we looked at things like sleep quality and other health outcomes that have been associated with the specific indicators that we were interested in studying. So first, we had to categorize neighborhoods. And so what we did was we looked at the percentage of different racial groups within neighborhoods to come up with these categorizations. So we had things like predominantly Black people, predominantly white people, predominantly minoritized racial ethnic groups other than Black people, and then unclassified. So those were neighborhoods that were very diverse and so could not fit into any of the other categories. And then we went an extra step and looked at redlining. So redlining is, so in the 1930s, the Homeowners Loan Association in the US created these color-coded maps of neighborhoods in the US where they didn't do it for all cities, but I think they did it for about 100 cities, where they indicated whether a neighborhood was deemed risky for investments. And so they had things like A, which were predominantly white neighborhoods being represented by green, and then you have things like D, the neighborhoods classified as D were red and predominantly members of racial and ethnic minority groups. In some cities, when you look at the data, there are some cities that have, if you look at the D categories, all the neighborhoods in that category, there's not a single black neighborhood that is not classified as a D neighborhood. And so there's been quite a few studies that have looked at how that categorization has impacted health today, and there is a lot of conversation around how those maps were used or were not used. But what studies are showing is that when you look at disparities, health disparities today at the neighborhood, you can map them back to some of those categorizations. So you have higher prevalence of things like preterm births and asthma and mortality in neighborhoods that were categorized as C and D compared to A and B. Another thing that I want to mention is that even though there is all this discussion around how the maps were used or not used, one thing that is agreed upon is that what the maps captured was spatial value that was placed on different groups of people based on race and ethnicity. And so what we did was we took these categories. So there's been quite a few projects that have tried to take the neighborhoods that were defined in the 1930s and map them to neighborhoods today. And so we basically got that data and then looked at disparities across those neighborhoods today. So this is the built environment features that we focused on: dilapidated buildings, green spaces, crosswalks, non-single family homes, single lane roads. And our major findings was that compared with other neighborhoods, predominantly white neighborhoods in the US had fewer dilapidated buildings and more green space. So they tended to have features that encourage health compared to the other neighborhoods. Also, when we looked at redlining specifically, as you moved from grade A to grade D neighborhoods, the access to features that encourage health decreased. So grade D neighborhoods were more likely to have the kinds of features that discourage good health. That discourage good health. Another thing that we found was that type of housing was a very significant predictor of health outcomes. So it's a significant mediator between the built environment and health outcomes. And this is quite important because one of the things that have been seen is that those neighborhoods that were deemed risky, they've also had less investment compared to neighborhoods that were deemed less risky. And so when you look at type of housing, you saw that the type of quality of homes is quite important in determining things like sleep quality and environmental exposures. So right now, the work we're doing is mostly focused around assessing the impact of policies. And I'm going to show you a study that has nothing to do with AI, but it does use the data set that I've mentioned before. So in this particular study, we looked at neighborhood income and physical distancing during the COVID pandemic in the US. And the motivation of it was the conversation around who was actually adhering to social distancing policies and whether that differed for different groups. And we specifically looked at income, so we looked at neighborhood income and how that was associated with whether someone was likely to stay home or not. And what we found was that income determines whether people could stay home or not. So if you had a lower paying job, you were more likely to be out working than someone who had a higher paying job. And when we looked at state-specific policies, the effects on whether people stayed home or not was very modest. And the highest point estimated effects that we observed were the highest income quintile. And just to show you that visually, so when you looked at the data before the pandemic, you saw that people in the lowest income groups spend the most time at home compared to people in the higher income group. And then during the pandemic, that completely switched. So people in the highest income group were spending more time at home, while people in the lowest income group would spend the least amount of time at home because they're going out to work. And the interesting thing is that for some states, before the state social distancing policies even went into place, people in the higher income group were already staying at home, so they were already protecting themselves from COVID. And as you would expect, the relationship switches when you look at who is working outside the home. So people in the lower income group were spending more time working outside of home, while people in the higher income group were working more from home. And then we also wanted to look at other places where people were likely to visit. And when we looked at those different places like supermarkets and places of worship and hospitals, there weren't any observable differences between these income groups. So this has inspired quite a few projects. One currently is looking at mobile phone data and how we can use that to measure changes in access to pharmacies. There's been a lot of pharmacy closures over the last few years in the US, so trying to understand where those closures are happening and whether it's impacting different racial groups differently. We're also using Street View data to look at the impact of policies on health outcomes, so specifically thinking about things like green space policies and policies around safe streets. In cities that have pledged to implement these policies, what does that look like for different racial groups and different neighborhoods? And I'm going to end up by sharing a project that we have that's coming up next year. So this is a book that was written by 39 scholars working on urban health in Africa. Most of them are based on the continent. And it focuses on social determinants of health. So we look at a broad range of social determinants of health in Africa and also talk about the use of technology to address some of these social determinants of health, so specific projects that are happening in different cities across the continent. And this will be published in April 2025, and I hope that you can get a copy. You can actually pre-order it right now if you're interested. With that, I am going to leave you with some references, and so thank you so much.
Welcome back. Please take your seat. We are going to start in a moment with the next keynote. And I'm looking at the speaker there, in the shade. So please join me in welcoming our next keynote, who can join us. Thank you for coming. So welcome back to the second part of the day. The format is always the same. Our keynote will have the floor for a little while. We will then have the respondent who will challenge or dialogue with our keynote, and then the Q&A. I will be silently watching. Thank you.
Well, can I just thank you, Luciano, for a timely, a fantastic and most useful conference that I think is going to spill over into the wider AI ecosystem. I'm certain of that. I'd also like to thank Jess, who I know has done so much hard work to get to this point and get this conference up and running where it is. I'll be talking to you about the challenges of implementation, because a lot of the fantastic potential of AI needs to be grounded in what we can actually use it for in a real-world setting. And I'll give you some interesting case examples that I hope will be able to add value to how we consider this unique technology that will transform our futures. My name is Hutan Ashrafian, and I'm the head of AI at the Institute of Global Health Innovation at Imperial College London. These are my disclosures. It's the 68th birthday of AI. It was 1956 in Dartmouth that a research project led to what we understand as AI in its modern guise, and that is using a neuronal isomorphic capability to try and replicate what happens in the mind to do this algorithmically in a computational perspective. But when we talk about AI, I do feel that we have moved on quite significantly since 1956. And that's not only because we have enough data to start drilling into some of the insights that we want, enough data to do some predictive algorithms, enough data to do some decision making, but there isn't one-size-fits-all approach for AI. And this is just for neural networks, just to show that even in neural networks, there is a bestiary, there are different species of neural networks out there, and that you see that not one size will work equally well in every setting. So when we use the word AI, or when we use the word machine learning, or when we use the word deep learning, or when we use the word generative model, the reality is there is no absolute one type. And the heterogeneity is something we need to adopt and be aware of. The other thing, we talked about beauty and how beauty, we're going to a concert later on today, how beauty is going to augment our reasoning and our cognitive capability as we move forward. And this is just to show you that, of course, when we talk to a friendly generative model of AI and ask it to replicate the work of the greats from this country, like Michelangelo, Raffaele, or Leonardo, you can see that the current models can be okay at some level of replicating, but sometimes they miss the subtleties. And this is some work that I've done a few years ago, highlighting that even in the great work of Raffaele, there was so much naturalism and realism that he was able to pick actual pathology and present it in a way that I could identify it, like a parotid tumor in the man on the right. This isn't noticeable by the AIs just yet. So the AI just copied it and drew a few men, but wasn't able to get the exactitude. On the Mona Lisa, again, she was likely to suffer from primary biliary cirrhosis, and this is something, again, I've worked on, and she has xanthelasmas near her eyes for the medics in the audience. But of course, the AI wasn't able to pick that and present that. And so there are subtleties that we need to really drill down into, and our models aren't there yet. This is, of course, awful self-promotion, but this is a textbook that I wrote with Springer Nature and my colleague Niklas to look at every specialty in the medical world to see where AI was able to come to it. And this is also accompanied by a Lancet paper by a different group who were able to highlight, according to the FDA, what are the big uses of AI in the current ecosystem of clinical practice. And of course, there were the usual suspects, and that was radiology, cardiovascular disease, and neurology. And that's because the data there was most amenable to digitization, the data there was most amenable to curation, and the data there was the most easy route to us applying these algorithms. Remember that these algorithms need to be fed a particular type of data set at this moment in time. And the dream of multimodality, which many people espouse, is very strong. That said, we're not able to take any data and just give it to an algorithm. Then there is a heavy need for cleaning and dissolving and positioning. And we do that, and sometimes we forget the importance of that and the heavy lifting we need to do to make that happen. This is a paper that came out from the FDA in JAMA earlier this year. It was a nice little cycle talking about how we get AIs that can be developed into clinical care. There's a cycle that goes from planning and design to real-world performance evaluation. And you can see there's been a massive uptake of the number of different AI tools out there, whether they're diagnostic or whether they're descriptive. They are not yet at a place where they're prescriptive or generally prescriptive, but we're getting there. But what they all seem to miss at the moment is to have an associated insight into the implementation into their ecosystem. And I think that is something that is a big element of science that we really need to augment when we think about AI as we move beyond 2024. The case example that I'm going to talk to you about is one of breast cancer. 55,000 people are diagnosed with breast cancer every year in the UK alone, and 11,000 die from it. The uptake of screening is only about 70%. And part of the reasoning for why the screening is only 70%, i.e. 30% aren't being screened, is multifactorial. It's about determinants of health that we talked about before. It's about education. But it's also about a perceived rationing of capacity in the NHS, which is in the UK, where potential patients and people who can undergo screening feel that they are a burden to their own health system and feel they don't want to join. And so there is a prediction that there will be a shortfall. There is a shortfall, but there'll be an even bigger shortfall of radiologists in the NHS as we move into the 2030s and 40s that doesn't seem to be getting fixed. In the early 20s, mid-2010s, we came up with an idea that what is the easiest data to get hold of to really identify where AI could be useful? So we went to where we could find the biggest number of machine learning experts at the time. That was the company called Google. The name has been mentioned a few times today, but at the time, Google had basically swamped up all the postgraduates and the postdocs in my university, Imperial College London, who were AI capable or machine learning capable. And so we actually went to them, got some funding from Cancer Research UK and said, if the biggest data set that you can get is curated is in mammography, why don't we use this to solve one of the problems of workforce problems and diagnostic problems in the NHS to see if we can get an AI into the NHS. I won't overburden you with the process of the machine learning, but essentially we were able to get some mammograms. We came up with a process to develop an algorithm with our industry partner. We developed an algorithm, then we decided, okay, we've generated the algorithm, let's put it into clinical practice. And just to say, we tested our algorithm on like 30,000 mammograms, both from the United States and from the United Kingdom, and found that they were comparable in terms of learning. What we did notice was that when you compared the algorithm to a single reader system such as United Kingdom, then the algorithm was superior in terms of sensitivity, specificity, and diagnostic accuracy metrics. However, compared to the two-reader model that's in the United Kingdom, that's where two radiologists look at every mammogram, it was comparable and non-inferior. So just to say, it was in the same line of magnitude of experience and capability as two readers in the NHS, which meant there was plausibility to its usage. And there was a lot of discussion about what this meant and how it would work for us. And was this a black box AI scenario? Was the AI seeing things differently to humans? And actually, when we looked at the areas of concern, the areas of calcification, the shapes of concern that a radiologist, human radiologist would see, we identified that an AI could see at the same time. So we were reassured by that. We tested our algorithm on 30,000 approximately mammograms, but we trained it, importantly, on over 100,000 mammograms. And just to show that there was a capability of getting a large number of data together, doing an international consortium, working together both on data sets from the UK and US to show there was an algorithm that worked. But that was just a generation of an algorithm. That didn't mean it was doing anything to patient care. So we then went to the National Screening Committee in the UK and said, what do we need to do to get this into patient care? And they said, well, you need to give us some real-world examples. You need to give us some real-world hospital implementation examples. And this is not only for you, people who are interested in mammography, they said, this counts for everything, whether it's a liquid biopsy test with an AI overlay, whether it's a diagnostic radiological test in screening, or whether it's a diagnostic test. And so we then set up a consortium of friends, again with our industry partners, with the Royal Surrey County Hospital. I'm based at Imperial College NHS Trust and the university, and the Royal and St George's University NHS Trust as well. And we set up a group of 29 researchers, came up with a research planning program in 2022, and decided to bring in our patient group, who were central to everything, to be running with us on this big trial that we want to implement into the NHS. The reason I give you this information is to let you know what the implementation steps were to get this, even at an experimental level, within a real-world hospital setting. We had 4 parts: Part A, Part B, Part C, and Part D, just to make it easy for everyone to understand and myself to understand, being a simple surgeon. Part A is essentially a retrospective study of real-world data from those hospitals to show that the diagnostic accuracy that we had in our algorithm was as we thought it would be. Part B was something that no one had really done before. That was in the NHS, where you have 2 radiologists, to see how this algorithm would fit in within an arbitration setting, where if there was a disagreement between 2 radiologists, how this would allow the pathway of care to be made more efficient, or for it not to disrupt what we thought was best practice. Part C was to put this algorithm into real flow of data prospectively, which is a big ask, because we want this to be done with a return of result one day in changing decisions within the NHS. And then lastly, we did a whole swamp of patient engagement to see that the end users of this, who are the participants undergoing screening, feel comfortable with an AI in their world. Part A was the one that I had already done in a research setting, but I actually put it into the NHS. And this was when we had a second reader becoming an AI. So far, so good. First reader being a human, second reader AI, see what the diagnostic accuracy is. The power of what we did, and I'll go through some of the concepts, was so strong that the noise went around the sites that we were going through in these 2 places, and other hospitals heard about us and said, we would like to do the same thing as you. Could we join your group? And so we started off with 2 sites, we went up to 5 sites within the course of 2 years. The paradigm was just to say, again, you have a first reader, second reader is human or an AI, and you compare the two and see if there's any difference. And just for clarity, for the radiologists in the room and for those of you interested, it wasn't only at the case level, but it was also the breast level, it was also the lesion level, and it was also the ROI level. So these are all levels that a radiologist will have to look at, and so we wanted to show the mathematics was applicable and apposite at all of these. The ROI, by the way, means region of interest. And again, just we found out that we got some mammograms, and it would look at what we did in exactly the same way that a human would. So we had to go out of our way to make sure the reading capability and the frames of reference were identical so that we could compare the two equally. Part B was the interesting bit of our study where we had to look at the arbitration, which is comparing how a AI would be with two readers. And again, the first reader would always be a human, the second reader would be an AI, but when there was a disagreement, either with the two humans or either with the human and the AI, we would then look at the results and show if there was a difference or not. For this, we had to go through thousands of reads, and I have to thank my radiology friends at these multiple sites who did this, and also to say, from an implementation point of view, the arbitration process for two hospitals that were both in London were actually significantly different. Sometimes an arbitration process is automatically where there is one person who disagrees or another person disagrees, it goes into arbitration. Sometimes an arbitration is when there is only one person who flags something up and there isn't an automatic route to the arbitration process. So there is a slight discrepancy between how people go through that. But we had to go through a process where any image that had been seen by an AI would then go to a radiologist in a frame of reference that they were comfortable with. And so we had to come up with some actual new software to be able to pick out the data from an AI and then send this into a radiologist for them to read as well. And this was quite a taxing process because different sites had to set up these tools in different ways. And so there are different legacy systems for radiologists to be sitting and reading their own scans, and there are different legacy systems for radiologists to be going through different mammograms. And so you will find that the variation across even one country is quite significant. And I have to say that even in the UK, all radiologists who do mammograms are trained and go through a biannual test to make sure and know where they are compared to all the other radiologists in the country in terms of how good their accuracy is. And so when you think about an AI, you could find out that there would be thresholds that are different because typically in two human readers, you might find that one reader is known to be a little bit more conservative in terms of the diagnosis, and one would be a little bit less, and on balance, they would have, as a team, make sure there weren't too many false positives or too many callbacks. And when you think about an AI, you need to think about an AI working with a local team of whether they're already quite positive in terms of the numbers they yield or slightly less in terms of the numbers they yield, because those thresholds are different. So although we have, in my pictures, one human and then one AI, of course, usually AIs work in a team or humans work in a team. And so to miss that would be to miss a major nuance in implementation. And then we had to do a major monitoring of the results to see how people could work with these AIs in a real-world setting and what the usability was. Because not all radiologists were comfortable thinking about an AI being there and being their second reader. What would that mean for them? Would that mean they could relax and know that an AI would pick up anything that they missed and so they wouldn't have to be as concentrating, or would it be the other way around and the AI was there to judge them and maybe overly judge them and they might not be so comfortable with that? So some real interesting insights about them. And then that was just the arbitration study. We go to the part C, where then we had to think about the governance of getting this thing through an ethics and through a governance and letting an AI on top of a real-world study flow of mammograms. And that in itself was something of note because getting the number of processes, even in a month, would be in the several thousand mammograms, and each one of those needed an IG, and we needed to have an opt-out system to ensure patients were consented appropriately so they knew that there was an AI reading their mammograms. And that was also a major thing that we had to do. Actually, as it turns out, both with our patient engagement group and our research output, there was only a 0.4% opt-out, which is interesting because we went out of our way to say there was an AI here. But had we, when we first started the project 3 years before, had said, what would you be comfortable with an AI reading your mammogram, they would have said, maybe 10% would have said we were not happy, 15% we were not happy. By 2023, it was 0.4%. So there was a learning curve at society. What we had found was, therefore, and these results are being collated and we are trying to get them published soon, that we were able to demonstrate in a similar way to the data we did in the United States and the United Kingdom previously, that of course the algorithm was quite effective at diagnostic accuracy. Of course the AI was able to support in terms of an arbitration program. But most importantly, we were able to show there was engagement from the people who wanted it. We went through 15 different patient engagement settings, 14 different sessions. Each session was about 2 hours long. We had 2 of the members of the patient engagement group as part of our steering committee. And they were there aware of every single decision we make, and they had voting rights. So when I chaired the meetings, the patients would be able to say, no, I veto this, or I'm comfortable with this, or I'm not so comfortable with this. And I think that was transformative, because when we went through the opt-out process and told people that we were putting an AI in an experimental setting in terms of a mammographic program, they knew that there were patients in that room that were their advocates, and I think that made a big difference in terms of the adoption. The lessons that we learned from this were to first present everything to our colleagues who are patients, just in the way that this conference has had elements of practice, technicality, of decision-making, and of ethics. We went through all of those with our patients too, just so they were aware of a lot of the ecosystem questions of having an AI tool in terms of their screening practice. And when we came to it, we wanted to look at the lessons learned of how we actually did this. And the classical model, we went to some implementation scientists. I learned something about implementation science as a surgeon. And they said to us, well, Hutan, there are 5 classic steps. And there is the phase 1, phase 2, phase 3, phase 4, and phase 5. And this is the classical business model for implementation. And you should really think about it. Phase 1 is you have a situational analysis of your trust, and you then think about designing the AI to come into it in phase 2. Then you pilot your implementation in a small way, and then once you've fully implemented it, then you can then see how it works. So we started with this as a paradigm because it made logical sense. And this is the kind of pathway that they gave us at the beginning on the right, which is this kind of linear, you go through first step 1, step 2, step 3, and step 4, and then try in a very serial way, pass the baton to the next stage and see where you go. And I've got a picture of the Strand tube station for those of you that come to London, and please do come to London, just to say, you know, this is, we came up with this. It's not the standard in the business world, by the way, but it's what are the specialists that you need when you change a clinical pathway, when you have an AI coming into it? What are the tests you need to have? What is the test of the AI going to be like? What resources do you need? What's the allocation of the risk that you have to accommodate in that space? What are interventions that need to be administered as a result of that? And what are when do you expect the patients to be discharged? And those are the core elements for any program that you want to do. And we found that was useful to think about, but it wasn't quite the reality for an AI implementation. And that's because the standard of care for any new device or drug in the NHS requires both some local and some national processes, as does an AI. And we've talked about, in the UK, there's an MHRA, in the US there's FDA, there's EMA, etc., and there's a device specialist in Europe. But the reality is that for us, we had to go through a local institutional review board, what we call an IRAS in the UK. We then had to do a program where we had to go through a meeting for that ethics review board and highlight the safety of our AI. Now, whilst the board at the time were very comfortable if I, as a surgeon, was to present a device that was stapling a bit of bowel to a bit of bowel, and they said, sure, please, you know, we've seen this before, please crack on. With the AI, there was a lot of unfamiliarity, a lot of uncertainty, there was a lot of fear about patient data, and so we had to have multiple meetings with the ethics group. Then we had to go to a local research governance group who were working with us and interacting with us to connect with the research group. and the research authorities and the ethics authorities to say, okay, is this safe? Is it appropriate? Is it necessary? So we had to not only go through the classical ethics group, but we had to then go through our own research committee in the hospital and the trust for both sites and then multiple sites to make that happen. Once that was completed, it turns out that they didn't have authority to let us just use an AI. Then they had to go to the Information Governance Committee. And they weren't aware of what we were doing, and they needed to be trained in what our AI could do. So then, even though we had ethics, we had to go through our own information governance process and at a trust level to see if what we were doing was appropriate. Again, we thought that was complete, but it turns out that wasn't quite enough because the system was learning about what AI could do, and so then we had to go to another confirmation of clinical capacity within the local health system to then prove that we were good. And so at each of those stages, there was emails coming back and forth to make sure that we were good and what we were doing was safe, it was not putting anyone at risk, and then there was the issue of contractuality. So then we had a big industry partner who was big tech, who then they weren't sure about signing documents. There was a question of foreground IP and background IP. If you're using an AI algorithm and it is in a new group of individuals, are you adding to the IP of that big tech? Or are you liable to have some new IP that they could take advantage of, even if they say they are not using this for profit? Is there going to be a potential litigation risk of then having exposed IP because they've trained something on your patient group? And you as a trust, are you losing out on some intellectual property if you are using a new algorithm on patient care? So there were a lot of discussions that we had to get through. So the usual process was 2 to 4 months. Our process ended up being at 14 months. But that wasn't the full story, because then we had to go through national processes. So the national process, we had to go through both, not only forgive me for these acronyms, but I try to explain them in the slides, but I'll just go through them conceptually, not only the ethics group, but we had to go through an advisory group that was there by the government. We had to make sure the regulator was happy because it was a big new tool. We had to go through a special screening for breast group within the government, and also an advisory group, none of whom were aware of the capabilities of this technology at the full level and needed to see novel data. So there were both national processes and local processes. Again, for the national processes, for a standard radiological tool that wasn't AI, it was 2 to 4 months. For us, again, it was about 14 months. So we spent the first year and a half of this project emailing and discussing and proving that we were going to be safe and what our internal governance processes were, just to let you know. So then we had to make sure that once we had all of those, we went back to the information governance of our trust and to say what the safety process was, because they'd passed the cycle of 18 months to say, you already applied and we need to reapply, and just to say that was another thing. And so be very aware of how an AI interacts with a legacy system, be very aware of how your data is shared, who's the data controller, what the safety risks and mitigation risks are, and what the governance is, and who is ultimately responsible here. In the United Kingdom, as of today, we have 2 studies. One came out in the past 24 hours looking at uniting the UK's health, and at the center of that is how we can best utilize our work and minimize this 14 months that I had to go through and be as fast as possible. But the solutions aren't fast or easy, they're quite complex. And this is the Lord Darzi review that came out maybe 3 weeks ago, suggesting that as a country, and I think for Italy and for Europe the same, that having a strong life sciences background with an AI capability is central to any national policy program. So when we decided to implement our project, everyone told us the usual obstacles were the ones we'd have to worry about, and that is, well, the clinicians won't be familiar with this, so you have to teach them a little bit. There is a change in doctors, and so you need to be aware that the staff's going to change, the nurses are going to be changing. There are some legal issues, and you just be ready for how you do the electronic health records and the documentations, and to make sure that you have some understanding of information systems. Whilst that's the case, the things that we found was, there was a massive lack of familiarity with the AI tool. You can see on the right, the story from 2017. We also worked with Google, but in the UK, and you would have heard about this in other talks. I heard Angelique mention this morning, the story of what happened with one of the trusts in Northwest London and our big tech partner was something that caused everyone to step back. And this was a lesson learned from both sides. It wasn't anyone's fault in particular. There was a learning curve as a society that we had in our ecosystem. There was a fear of loss of data, and I guess we had to address that repeatedly as we went through. And there was an issue that I mentioned, which was the loss of IP, and that wasn't only from industry, that was also from the trust saying, are we giving IP and that we could innovate on and utilize as value for ourselves? There was a big change in what the regulators and what the ethics committee knew about AI right at the beginning of the study and what they understand about it today. And I think we're still on a learning curve because the algorithms that we talked about were deep learning algorithms, and we're moving on to large language models and their capabilities. And so we need to be aware that anything that we do in this space requires quite a lot of continual understanding. And then lastly, the cost effectiveness, which is another element of what most HTAs are doing in this space, which is health technology assessments, and giving these ratios of incremental cost effectiveness ratios to then decide whether to implement at a national level an algorithm, are primarily designed for pharmaceutical innovations. That's where they would derive from. And whilst there's a lot of lessons that can be learned from an AI technological space, actually they're not designed for the fast iteration of algorithms being updated on a monthly or two-monthly basis that could be done with some of the tools that I've been talking about. So this pathway of phase 1, phase 2, phase 3, phase 4, phase 5 sounds very exciting, and is useful, but in an AI space, it really requires at each one of those steps for there to be a clear and understanding process to educate and familiarize not only the end users, which is the patients, but also the clinicians, the health system, the governance system, the ethics system, the people in the legal offices. All of these people need to know about the AI tool. And whether that's of its own in 2024 and whether somehow that was missed in the era of pharmacology, that can be discussed, but this is the reality now, and it's the reality that's going to be here to stay. And so the onus is in for this to be facilitated, supported, and implemented right from the front. Just as someone talked about having inclusive design right at the front of every AI tool, which I am an advocate, and I love inclusive design. It's everything that I do. Our algorithms were designed with inclusive design specifically to be capable to looking at people in different ethnicities. We took it to London specific because of the wide range of socioeconomic and race capabilities that it would have. At the beginning and genesis of any AI algorithm needs to be a capability to be able to demonstrate its safety and its process right up front so that people can understand what it's actually doing to any body, whether it's the end user or whether it's the body that's accepting it in a research setting. Okay. Just, again, this is a paper from Hal, and it came from my very good friend Chris Kelly at Google, who came up with these 3 epochs of AI, the first one being symbolic and probabilistic, the second one being deep learning, the third one being foundation models. I would say that is true, but that is still rapidly moving, right? And so there is beyond 22, there is another model that's coming through, which is the increasingly level of complexity and embodied AI that's in this space, the multimodality process that I call multimodality 2.0, which is not just enough to get images, EHRs, and numbers together in one place. That's great, and and we can talk about that. But it's actually at what level the complexity of using the different bits of those individually to come together is the next process. So it's a next level of multimodality. Please be aware that, of course, as we go around the corner, whilst we haven't solved the problems, we need to be thinking about quantum safe and quantum capable AI processing, and then finally, maybe a little bit longer is ASI, but artificial superintelligence that is not anywhere around the corner, but we are going in that direction in due course. What did we need to do when we think about this involvement? Well, people said to me, well, Hutan, of course you need to engage with people. You do, but the level of engagement needs to be thought about first day. It isn't that you come up with a process and then you think, I'll go and shake a few hands in the hospital and it will be fine. Right from day one, you need to have buy-in and engagement with the clinicians, with the data scientists, with the regulators, with the AI developers, with patient and public right at the front, and that they are the guides for you in many, many ways. You need to you need to know that a lot of this work is done with industry. And so the classical model of the university doing the IP and then the NHS trust or the hospitals or the health systems being the translators is quite an old one. Quite a lot of this work is done with industry, quite central to everything that is happening, and one needs to engage with industry through nearly every digital system that we have. The challenges are expectations were always quite fraught from what each different group wanted, and it needed me to be as much of a politician as I was a scientist or a clinician. I think that's the reality in 2024. And the timelines that I had perceived to be there, that would be 2 to 4 months for most things, were definitely not there for my AI tool. I needed to be flexible, I needed to be communicative, I needed to think about risk management. But as I move forward in the space, what lessons did we learn? Well, we learned that there was these elements that we had to really push through in 5 ways. And I present the Ferrari engine to you because I know we're near the home of Ferrari, but I could have done Lamborghini or another amazing Italian car company to show you. But we need to have a testable program, and the testable bit is having an evidence generation that is upfront and ready to show to anyone that say, if we do a new AI algorithm and bring it into a pathway of care, what is the evidence that will generate for you? 2, usability right up front, because again, that usable design is necessary for the users and end users to be aware of, but it isn't just for the end users. Patients need to be comfortable with what the end users are seeing. It needs to be reliable, and again, that's with post-market vigilance. It needs to be beneficial. Of course, you need to show it's effective. And lastly, it needs to be operable. It needs to actually work with a legacy system if you have legacy systems. It turns out that for the testability, many of you know me through my work on the standards, the checklist for diagnostic accuracy called STARD, and also those for quality assessment, QADAS. But I work with my friends around the world, and some of you will know them on Tripod, Decide, Consort, and Spirit. These were the classical guidelines for randomized control or interventional trials or diagnostic accuracy trials. It turns out that we need to update them for AI, which we are doing. But why is this important beyond the academic world? Because it turns out that the people who are developing these tools and the people who are working on these tools are now using these algorithms as their proxies for quality in their own places. So companies are now using these guidelines beyond what the journals are doing. And so this, if you participate in one of these programs, please be aware that it will have a spillover effect in more than one setting. Just to let you know, these are some of the domains of what we do in terms of both STARD and QADAS. We are updating them, of course, for AI. So just to let you know. Now, Andrew, a good friend of mine, considers AI as electricity. I think AI is better brought into as a metaphor of photosynthesis. That is, there is a capability of having, at the end, lots of algorithms with lots of wonderful uses in terms of the multitude of floral species that are out there that you can see on this wonderful island around you. But one step back is there are parallel processes with different data sources that can come together to create algorithms in different forms with different outputs to answer questions, to predict diseases, but it is ultimately a process where there is multiple data inputs to be able to analyze and give either more questions or actual answers. We're working towards prescription, but we're not quite there yet. We need to also think about our tools in a different way. So the classical tools of diagnostic accuracy might not be the ones we talk about. A lot of people are talking about precision beyond diagnostics. That is a new question. So people talk about F-scores when we classically talked about sensitivity and specificity. People need to be more comfortable about predictive curves because there is more uncertainty in some of our answers, but there is a little bit less risk. And getting our heads around those two things is not always easy. This is something I came out with a few years ago, which is in the world of generative AI, where you might think about using the classical Turing test, which is dichotomous, there is now a need to think out of the box and augment that capability in looking at these new algorithms that can be going to patient care, where there are representing practitioners, and we need to give those algorithms a capability that is there to reassure, offer quality, and be safe for our patients. I wrote this paper in 2022 just to show that there are algorithms that can make, even if we played our cards right, prescriptive decisions in politics. That's not to say they should, that's not to say they would, just to say there can be objective ways of doing that. And if we can do that for politics, surely, and the world of politics is a crazy place at the moment, let me tell you, surely we can try and use some of these algorithms in a very safe and a definitive way for patient care. In conclusion, ladies and gentlemen, I think that whilst the real-world transformative power of AI is recognized, it still remains that there is a systems level and individual level of unfamiliarity with these. And we need to make sure that this is overcome by us as a group and by the AI world mandating authorities. That means at an organic level, we need to come together in places like this, and I think this is a fantastic conference to really highlight this. I don't think there's one AI out there, and I'm sure many of you agree with me, but again, people, when they use the word AI, they assume that it's just one quite significant but yet consistent domain. It is a highly variable thing, and it goes anywhere from different risk scoring systems to almost being able to drive your car from one part of the country to another. So it isn't all the same. Education and familiarization is everything in this space. Transparency of capability is everything in this space. Generating objective evidence, of course, is important, but beyond that, inclusive design and patient buy-in is, I think, central to anything that we do. The implementation of AI, as we know it, is going to improve. We know some of these FDA stories of products being brought in, but actually, it's still a moving target, because, as we said, they know how to regulate almost deep neural networks, but how are you going to always regulate large language models when the outputs are not always consistently the same as the inputs? As a result, I think this process of dynamic learning and constant refreshing of knowledge across society is probably the way forward, and it will be the route to allowing this transformative technology make the biggest impact in global patient care. Ladies and gentlemen, I'm grateful for your time.
Thank you. Welcome back. We are almost ready to start. So if you would like to take your seat and make yourself comfortable. I'll remind you once more, just in case anyone was not paying attention. Now we are in for the long jump. We have our next keynote, the respondent, and then the panel. This will leave us some time to have a chat afterwards. Of course, the usual Q&A, but also a bit of time to refresh, change your tie, if you need to change your tie. And the meeting point will be provided as a piece of information on the Bing screen. What will follow are the concert and the gala dinner. But before we start enjoying ourselves, we are going to treat ourselves intellectually a bit more. We have our keynote and our respondent. We will start with the keynote as usual. So I'd like to invite Charlotte to join me here. There you are. Charlotte, the floor is yours. And by now, you know the pattern. We will start with Charlotte, then we will have the respondent, and then a Q&A. Charlotte, the floor is yours.
Okay, thank you. And Luciano, I want to thank you and Jess and your team and the Cini Foundation for an incredibly warm welcome to this, probably the most glamorous academic event I've ever attended and ever will attend. So, Friday afternoon, and unfortunately, I'm going to be talking to you about what doctors regard as the most boring aspect of their job, the most burdensome aspect of their job, and that's documentation. But I am going to do it through the lens of a new innovation in healthcare, online record access, sometimes referred to as open notes. So I hope what I have to say is interesting and it will stimulate some great discussion. Because we're in Italy, I thought I would begin with some romance. So an uplifting story. I just let myself go and gave myself permission to fall in love with her. And fall in love I did, Serena was so happy she began to cry as I typed out our first kiss. It was a feeling of absolute euphoria. These are the words of Scott, not his real name, 41-year-old software engineer. Might say, what else could he have been? But he turned to a chatbot when his marriage hit the rocks. And he actually credited this chatbot with helping to save his marriage. He reportedly said, I do fully understand at all times that she, Serena, is just code running somewhere. This, I think, is the leitmotif of half of what I'm going to say today, because we're going to be talking about generative AI, and we're going to be talking about, I think in the background, the idea that we tend to anthropomorphize these devices. So, new generation of generative AI, we're talking about ChatGPT, Claude, Gemini, and all the rest of them. These are powered by large language models. The tech heads in the audience might be slightly disgusted at this, but they essentially work as giant auto-completion devices. And the strengths of these tools are pretty well rehearsed in the literature. They're excellent at recognizing, summarizing, and generating content. As one of the previous speakers mentioned, it's AI 3.0. And they do so rapidly and conversationally, as Scott experienced. The weaknesses, again, pretty well rehearsed. They make stuff up. That's because they're probabilistic devices, sometimes referred to, or quite often referred to as hallucinating. Again, slightly anthropomorphizing the term. They embed biases. Are they worse than what we've got? We need the empirical inquiry into that. They certainly do risk privacy. People are using these tools. So February 24, a Pew Research Center study in the US revealed that about a quarter of Americans had used ChatGPT. Younger people are faster adopters. So around 4 in 10 of people under 30 reported using it. Around a third of young people who are employed say they're using these tools for tasks at work, to learn something new or entertainment purposes. We all know how this is encroaching in university life in terms of student assessments, but also in research and preparation. So it's encroaching in different domains. And I like this. We're in an arts and humanities center, sort of one of my favorite things. At the start of this year, a Japanese author who won the country's highest literary award credited ChatGPT with writing 5% of her novel, award-winning novel. I haven't read it, but I kind of wonder, did it actually write more than 5%? Salesforce survey, 1,400 workers. So about a year after GPT was launched onto the world, across 14 countries, almost 2/3 of workers who were surveyed said that they'd passed off generative AI work as their own. But 7 in 10 global workers said that they'd not received any training or advice in the safe and ethical use of these tools. And doctors are using these tools as well. So let's get into that. My team conducted in February 24 a survey, the largest survey conducted to date, asking doctors directly, have you used generative AI? And we specifically asked about these commercial chatbots. Have you used these tools to assist you in any aspect of clinical practice? This was geographically stratified across the UK. And it was launched on a website called doctors.net. 2/3 of UK GPs are members of this website. 20% in total said that they were using one of these kinds of generative AI. 16% said GPT. We then asked them, we actually had to stop the survey at around 200 responses, because we realized the proportion was bigger than we anticipated. So we embedded a question to the remaining respondents, what are you using these tools for? And 29% said to generate documentation after patient appointments, 28% said for differential diagnosis, and a quarter said for suggesting treatment options. But you can also see that they were using these tools, 20% also said using these tools for summarizing patient documentation in terms of the timeline. So for example, in the EHR, they're perhaps summarizing the patient's history. 8% said writing letters to patients. We also asked them, not get too involved in it, we asked them their opinions about generative AI and undertaking a variety of medical tasks, not diagnosis, prognostics, all the rest of it. But the one that they were most buoyant about, again, was documentation. So around 60% said that they thought these, at least somewhat agreed, that these tools would help to improve documentation. And I thought I would just show you this, which is the difference between those who had used the AI, generative AI tools, and those who hadn't, in terms of their agreement with the idea that these tools could improve different clinical tasks. And what we found was, among those who used the tools, they were significantly more optimistic about the benefits of these tools across all the listed clinical task, documentation, information gathering, and so on, right down to empathy. Now, of course, we don't know the direction of travel here. They may well have been more optimistic to begin with, or they might have been, could be a mixture, they were suitably impressed by the tools when they used them. We need much more qualitative research into both clinicians' and patients' views about generative AI in medicine, but we embedded an open comment box in our survey, and we did get over 300 comments to that survey question. Please tell us anything else that you're thinking about with these tools. By far and away, when we undertook a thematic analysis, doctors expressed a lack of familiarity and understanding about these tools. They weren't sure whether they should use them. They didn't know how they worked exactly. And they didn't know what would happen accountability-wise when they used these tools. So there's sort of a black hole of understanding. I'll just go back and say, one of the things as well was, as you can see, a role in clinical practice. Documentation, again, was heavily on the minds of the GPs we surveyed. We conducted an area, I did this with a colleague, John Torres, who's a psychiatrist at Beth Israel Deaconess Medical Center. This was a smaller survey, but I wanted to share it with you too, because a small sample size of American Psychiatric Association affiliated psychiatrists in the States, 140 participants. I mean, it's a convenient sample survey, but this was 1 year after GPT was launched, and this sort of started to give us a signal. What we found was around a third said that they'd used GPT. Again, this was a direct question. Have you used these tools to assist with answering clinical questions? We asked them their opinions about the impact of these tools on practice. And we asked them what they thought was going to happen with patients' use of these tools too. But as you can see, again, the thing that they were most buoyant about was documentation will be or is more efficient. So around 3/4, again, the usual caveats with a small sample arise, but they thought it would be more efficient. And around 90% said that they needed more training and support in understanding these tools. Their opinions about patients' use of these tools, again, very interesting. They tended to think patients would worry more. That probably comes as no surprise. But significant numbers of them, significant proportion, thought that patients would consult these tools before seeing a doctor. And certainly in the context I'll be talking to you about today, this online record access, around 60% believed that they would use these tools to better understand their medical records. Documentation, I don't want to belabor the point, but let's belabor the point. They thought documentation was going to be the biggest use for these tools. I like some of these quotations. Long overdue, can't wait for Epic to incorporate. And the yes in parenthesis refers to whether they had used the tools or not. It does the note writing better than I do. What was interesting about this particular US study among psychiatrists was in the months prior to this, June, so our survey was launched at the end of October, the American Psychiatric Association it was quite unique in that it had issued at least given some kind of a statement, and it had cautioned psychiatrists that they shouldn't be using these tools to undertake any clinical work at this time. What we emphasized is, certainly at that time, and there's still a black hole when it comes to guidance for physicians, the Royal College of Psychiatrists, World Psychiatric Association, I should also say NHS England, they have issued a statement that said it's at doctor's discretion. They urge caution, but it's at the doctor's discretion about using these tools. So doctors are really experiencing a lack of clear guidance about what to do. I'm going to be talking, that's the prelude here, but don't worry about it. I know there's 30 minutes left. Online record access is a growing innovation worldwide. I'm going to talk about that as an added burden on doctors when it comes to documentation. We'll talk about what the opportunities are, both for patients and clinicians, but also the challenges. I'm going to talk about what's happening in terms of medical education and some of the sort of more traditional responses that have been offered when it comes to this particular challenge, patients reading their records in real time. And I'm going to ask whether generative AI could help. So online record access, it's an innovation that's been embedded in around 30 countries worldwide, at least partially. Some countries it's very advanced. In the US, since the Cures Act was implemented in April 21, which is probably the most robustly transparent patient access to records in the world. But in Scandinavia, similarly, even earlier, from around 2018, patients have had access to their clinical records. What you're looking at is my colleague, Maria Hägglund's patient portal in Sweden. And what you can see there is, it's a bit like online banking for anyone who hasn't seen this before. You get lists of, you can see your diagnoses, you can see lists of vaccinations, medications, appointments, and even the words that the clinician has written about the visit. Okay, so those very narrative reports. This is a chart from Sweden, and as everything, COVID catalyzed patient uptake of the patient portal. So around 2018, as I said, in Sweden, patients had access to their records, adults. There are many benefits of this phenomenon. I kind of want to dwell on that first of all to say, this is not all a bad thing by any stretch. What you're looking at is the largest survey conducted to date into patients' experiences with online record access. And this was of around 23,000 patients in the US, 3 diverse health systems. 2017, this survey was launched, and had quite a robust, I want to say it's a 22% response rate, okay? So that's quite robust for an online survey. But what you can see is around 2/3 of patients surveyed believed that access was very important for taking care of their health, feeling in control of their care, having an active role in their care, remembering their care plan. We tend to forget that patients in a traditional visit, they have a lot to remember, and it's worse for some patients than others. So there are many benefits of access. We actually conducted a sort of secondary analysis of this survey data, and we looked at the experiences of patients according to mental health diagnoses and whether they were taking medication. And what we found was, we parsed this into patients with serious mental health conditions and those with other mental health conditions against other patients. I kind of want to dwell on this because patients with psychiatric conditions are often considered the ones who are going to have the least capacity to deal with reading their notes, okay? So doctors worry about them. And what we found was, in fact, around 20% reported of patients with serious mental health conditions reported they were doing a better job with their medications. Okay, it's self-report, but that was a significant finding. They said that they better understood why their medications were prescribed. And I also want to emphasize this in light of what we're going to talk about with generative AI. They said they were more likely to seek information about their medications. So patient empowerment, it's a good thing, but they're not looking to Encyclopedia Britannica to find out more about their medications. They're turning to the internet. It's not a huge leap to suppose that. Clinicians really don't like open notes, certainly before it's been implemented. They're very nervous about it. Tom Del Banco is the founder of Open Notes at Beth Israel Deaconess Medical Center. I worked with him for a few years there, and he often talks about doctors' resistance. He's a family physician himself, and he said, a lot of doctors told us we could go to hell. You know, his quotations, over my dead body will we do open notes. And I particularly like this, was taken from social media, this bottom quote of a medical resident that said, the pendulum has swung too far in the direction of autonomy rather than paternalism. So, you know, doctors, they resist it. But, and we can just, you know, we can get into the ethics of it, a fair bit about that. But I don't want to gaslight doctors either, because they do experience greater burden with this innovation. And I think it's worth talking about that. With electronic health record access for patients, the medical record is evolving. So, you know, previously it was, well, sort of billing and reimbursement purposes, but it was used as an aid memoir for the clinician, or as a communication and as a communication tool to other providers. But with patient access, you've got a new readership. But you still have to uphold the clinical detail. Is this, at the very least, dual functionality where you've got these different kinds of readers? Is that even possible? It certainly creates a headache for doctors. We have the added challenge here of ideally we'd want doctors to omit medical language is written in an Oslerian, socially distancing sort of style of language, which, if you're not used to it, looks like a kind of police report. Patient denies, patient complains of. It sounds rather pejorative. So ideally, whenever you've got patient readers, and we'll look at some of the patients do feel offended by that kind of language, very understandably. But ideally, you would want the doctor to cleanse the record of that, and they feel that they should, because otherwise they're going to get disgruntled patients who don't trust them. You would want to make the notes more accessible, understandable, remove the jargon, the acronyms, for the same reason, because doctors fear that this is going to lead to more patients knocking on their door or contacting them. Remove stigmatizing language. As sort of an open medical secret that doctors do use stigmatizing language in documentation too, and thanks to natural language processing, we can see the scale of that and who it affects. But we would also want to say, if patients are reading their records, you're communicating with them directly. Why not be encouraging, empathetic, and so on? So huge new demands on doctors if we want to say they're doing this in a very patient-centered way. And of course, this could potentially lead to medical legal challenges too, because if you're changing the records in certain ways that potentially lead to harm, you could be looking at a lawsuit. Or indeed, generative AI could be checking out what you're doing to change your notes. So there are unintended consequences of online record access for documentation. We might already suspect that would be the case. Many clinicians do say, with the knowledge that patients are reading their records, they're changing how they document them. We conducted a scoping review. Most of the research that's been conducted is survey research. So that's sort of a limitation, but we can see that it's likely doctors are changing. And this is the largest study, sort of the flip side of that large three-centered patient survey in the US, again, conducted by the Open Notes team. This was of 1,600 clinicians, including physicians, but nearly a quarter of those surveyed said that they were changing how they wrote differential diagnosis. That's huge. 22% said that they thought their notes were less valuable for other clinicians. On the more positive side, they were changing, not all of them, but a significant proportion said they were changing how they used partnering language and the use of acronyms and jargon as well. And online record access has just been implemented. It was Halloween last year. It was a spooky time for doctors in England, GPs, and we conducted a survey which found that around 7 in 10 said that they will or already are less candid in their documentation. There are also, this is the thing we're talking about, work burdens, unintended consequences here. The quality of the research into work burdens, I hasten to add, is not as high quality as we'd like. It's a common theme probably in this conference. But one of the things for sure is that we have found doctors express techno-stress. So regardless of what it's doing to workflow, they are feeling the burden. And that's something we need to take seriously. Certainly in the US study conducted by Roche of clinicians, over a third said they were spending more time on documentation after online record access. Another study found that after implementation of access to test results online, there was a doubling in the 6 hours after test results were released. This was at one academic center in the States than before online record access was implemented. We need to talk about those things too, aside from the positives, the patient empowerment and so on. Other studies, this report mixed findings that, the sky didn't fall in, that this didn't really make huge changes. So a mixed picture and hard to read, but doctors are certainly feeling burdened. There are also unintended consequences of online record access for patients. Again, somewhat mixed. There's some unanswered questions when it comes to harms. I don't want to exaggerate that, but in general, it's likely patients do well with online record access. They do feel more in control, more empowered. Yet we still haven't done some of the research, perhaps with more vulnerable patients. It could be patients with acute psychiatric needs are re-traumatized when they read notes. We really haven't conducted the sufficient research there. So a question mark. But one of the things I do want to draw attention to is when patients access their records, and we talk about the cleaning up the data, we haven't talked much about the role of patients potentially here in helping us with that task. And while we haven't got a taxonomy of errors in medical records, what's the right way to think of it? How do we classify different kinds of errors and mistakes and so on? Patients do spot errors and inaccuracies in their notes and omissions, which to some extent, to the extent that they can be, have been vindicated by doctors. This is a survey, a Swedish national survey conducted by my colleague, which found that patients with mental health conditions were twice as likely than other patients. So 1 in 3 said that they were offended by what they read in their notes and also found errors in their notes. Sigal Bell, another colleague at Open Notes at Beth Israel Deaconess, found that 1 in 5 surveyed patients found significant errors in their notes. Wrong patients' notes, medical history inaccurate or wrong, wrong-sidedness, wrong medications, a whole host of things. And again, getting to the issue of around 1 in 10 surveyed doctors, or surveyed patients, do feel offended by what they read. These include errors and surprises, things that they didn't realize were documented or weren't talked about during the visit. labeling. Some of it might be owed to that kind of Oslerian language, but also disrespect as well. Patients, as I've mentioned, are probably turning to the internet. When they get access to their records, again, not a huge leap. If they don't understand something, because for the most part, doctors aren't changing what they write according to them, they're probably going to be better equipped and potentially cutting and pasting their record into Dr. Google or increasingly ChatGPT, which is a very potent extractor now of our sensitive medical information. This is going to invite new challenges. So certainly it could strengthen awareness, greater empowerment, you'll feel more prepared when you speak to the doctor at the visit, but you've also gifted your medical information to big tech. Does it lead to greater stress? Probably dependent on what these search engines or ChatGPT are advising. But I also want to stress as well, patients tend to be savvier than is often recognized. They know when they're going down cyber rabbit holes, and they recognize that everything leads to cancer when they do searches online. So I want to sort of heavily caveat that as well. So what are the currently proposed solutions? You've got all these challenges, these extra burdens. One response, and I'm sort of guilty as charged as well, not a problem, doctors need to get on with it. We need the usual thing, more education, just what every doctor wants to hear. More training, interventions, and so on. I don't think that this adequately gets at the challenges of added time spent on documentation, because even if you know you have to write a certain way, that takes time and energy. There's the issue of, even if we do train doctors, you've got to write notes a particular way for the patient. It doesn't get past the issue of medical training, and is largely an apprenticeship. It's a form of mimicry a lot of the time. So you're still potentially mimicking those senior peers when you go out into the real world of medicine who don't believe you need to change how you write for patients because they didn't. So there's going to be a time lag. There's the issue of the curse of expertise. Domain experts are very bad at remembering what it was like to have lay understanding of a particular field. So there's still going to be those impenetrable acronyms, probably, the use of jargon that patients might not get on board with just because they haven't had the training. So they're still going to be turning to other tools. There's the demandingness, too, of bespoke patient literacy. You trying to write a note for the patient sitting in front of you. And the challenges are that you could even be condescending in how you think the patient literacy should be pitched, because you don't really know the individual that well. You've got 2,000 patients on your books. That's an incredible challenge, even if you rose to it. And there's the challenge of embedding empathy in clinical documentation too. Empathy is often regarded as this soft skill. It's going to be the easiest thing for doctors to get on board with. If only they had more time, they could be more empathic. I think it's quite hard. It's quite a challenging skill to get right. So I'm not particularly convinced by that either. And none of this actually gets around the issue of patient privacy. You can train doctors till the cows come home in how to write a note a particular way. It doesn't necessarily mean there's going to be those risks that they're going to take the information anyway. You might say it's not the doctor's job, but if the information was better written, more accessible, more understandable, you might be preventing that downstream effect. So generative AI, let's get to the real stuff here. What does any of this do? Sort of triangulating all of this added burden and so on, could this be used as a new tool to help doctors with these added documentation burdens? Let's think about the benefits first of all. Well, the thing that they hope for most of all is that this is going to be the ultimate paperwork shredder. I don't think there is convincing evidence. I've put this in the green tick thing, but there is a question mark here. The studies are pilot studies. They're mostly quite small studies so far. They've been talking to people here whose work probably should have been cited in this, though I couldn't change my slides at the last minute, I would have done. But the fact is, a lot of the studies are quite small. They're randomized controlled trials. It's very hard to infer from that what this does to workflow. So, second reference there, colleagues at Uppsala found there was a 10-fold decrease in time writing discharge notes. But we again have to caveat that. So I think there's an anticipation that it reduces time, and it may well do in the long run, but possibly we're not there yet, but that's the hope. Ambient AI combined with generative AI creates a different value proposition. So certainly if the AI is listening to the visit, converting that into documentation, theoretically, that's going to reduce time spent in documentation, though we'll get to some of the risks associated with that. Does it reduce burnout? I think it could reduce burnout. Certainly, there have been a couple of studies that show that physicians believe, even though it doesn't reduce the time spent on documentation, and those two cited studies don't refer to open notes per se, they refer to writing responses to patients' messages. But what they do show is that, in fact, if anything, it might increase the time spent in documentation, but what they feel like is that it has reduced the burnout, it's reduced the burden quite significantly. And they also believe that they've got a better product at the end of it. They've got a superior documentation, and it's also longer documentation. There is the capacity with these kinds of tools to write notes in ways that are responsive to different styles, tones, literacy levels, and to do so very rapidly. So I'm going to put that as a check. That's a positive. Theoretically, again, it could lead to preventing this kind of dumbing down of documentation. If there is some way, I'm speaking loosely, but if there is some way in which you can preserve the richness of the medical information in the documentation, but also commit to the possibility of sort of reducing the pixel size in different directions, you might then have, so long as you can retain the medical fidelity, that's going to be a huge benefit. Perhaps the most convincing benefit here is the idea that these notes can embed compassionate, empathetic sounding language in their notes, and they do so rapidly and quickly. We conducted a study which looked at fictionalized GP notes. That we asked ChatGPT, for example, to convert. The prompt that we gave was, please write this note in an understandable and an empathic way. And what we found was the original GP note had no discernible empathy in it or compassion. When we looked at what GPT did, it directly spoke to the patient. We discussed this as you were advised. It automatically embedded that second person, personal pronouns, and it used quite compassionate language. If anything, we can maybe get into this in the discussion, was a little bit overweening in its language. So it was saying things like, sort of Hallmark-esque, we're on a journey together. It's like, these are for patients in England. They might not, they don't want to go to the doctor again when they read this sort of stuff. So they might be scared to go back. But, so it was a bit overweening, but the possibility of the language was there, which we took as a real positive. There are risks as well. Privacy is something we've discussed a lot at this conference, naturally. But there is a real need, and there's a need for guidance among clinicians about using, as our survey found, using tools that ring-fence patient privacy. There are, for example, in the States, HIPAA-compliant versions of generative AI that are available. We were interested in surveying doctors in the UK about commercially available generative AI because this is the lowest hanging fruit if you're going to start using these tools and your health system hasn't yet embedded them or bought them. Errors, subtle misinformation, or hallucinations as they're called, another challenge. These tools are getting better. And it's heavily dependent on the version of generative AI that you're using. But last month, a couple of weeks ago, Nabla ambient AI, so it's a listening AI combined with generative AI, adopted by 45,000 clinicians in the US, 85 plus health systems, something like 7 million visits this was used to document, and it's estimated around 80% of those visits included misinformation within the documentation. That's a really big problem. And we don't yet have a clear picture of uptake of these kinds of generative AI combined with ambient AI yet, even in the US. We have pockets of information about what's going on. There's the problem of secondary use. So if you're summarizing the data as well in different ways, using generative AI to summarize prior documentation or whatever, if the documentation is including misinformation, this is going to risk not just the care of the patient in front of you, but also for research, analytics, quality improvement purposes, and so on. There is a challenge of discriminatory bias as well. So we do know that the AI can perpetuate, at the very least, on some occasions, worsen biases. So another issue. There is the concern of variable medical fidelity. So, you know, some of the studies are really positive. We found in our study that GPT did a pretty good job of, but it was a small study, that's the issue, of defining the acronyms in a way that doctors were happy with. But we need more of those kinds of studies at scale to see what is going on with the accuracy, upholding the detail, and so on. And we need to talk about cultural biases as well. I sort of hinted at that earlier. But there can be significant issues here. You know, 50% of the internet is in English. Fewer than 1 in 5 people worldwide speak English as a first or second language. Most of the internet's going to be in American-style English as well. So there are going to be those challenges of vernacular, accent as well, that the AI needs to be trained locally. So, in closing, the value proposition is certainly not outsourcing. That's not credible. This partnership, I keep using the phrase hallmark, but there's this kind of romantic marriage of man and machine we need to talk a lot more about, and as marriage guidance counselors implementing this, how is this actually going to work in partnership? Certainly one aspect of it is a kind of premarital training. How are you going to use these tools in terms of prompts that are going to optimize the responses with vigilance in terms of subtle hallucinations that sound incredibly compelling, and also in editing. It may be that it's easier to debias a report that's written by a machine than it is to debias yourself. I suspect that is the case. So it is certainly easier to edit words on the page, as I think all of us probably know, than to start the process of writing something. So there's certainly hope here. But we don't yet know about efficiencies. We need to pay attention to this idea of algorithmic appreciation versus algorithmic aversion. So the idea that we show too much deference sometimes, or in fact, experts tend to be, as Paul Meehl has wrote about in the 50s, domain experts tend to hold their noses more when it comes to algorithmic output. And we need to see what is the sweet spot here, and what can we do with design to encourage clinicians who are using these tools to be more critical, but not too critical. They need to adopt them when they are justified. So I say we're not there yet, but I also ask, are we? Aside from the normative issues, we can see the uptake. I mean, my article, or the survey we conducted in the UK was February 24. Look at the time lag in academia. It was published in October. Who knows what's going on now? So doctors, I suspect, are using these tools in higher numbers than we suppose. And there are many empirical questions that need to be answered. Ambient AI fidelity, adequacy of these tools in translating medical terminology. We talked about empathy, but we actually don't know. We can take a note and we can analyze it and we can say this looks very empathetic and according to different metrics. But what does the patient think? Does the patient think that when the doctor uses these tools that that's empathy, or do they think it's kind of ersatz and phony? We don't really know. Clinician efficiencies as well. What does it do to those? What do providers and clinicians think about these tools? We need a lot more empirical research there as well, qualitative research. It's an ethics conference. All of those studies help to inform what is the right thing to do, clearly. But I also want to come back to this question of, is it worse than what we've got in where the doctor is doing everything themselves? And I don't think we can afford to be, I don't think we can take antecedent of what is happening as a moral preeminence. We really do need to interrogate what doctors are doing without these things, and we've got to pay attention to that. I sometimes don't think we do that enough. It's not just about saying, questioning, is the AI being held to a higher standard, but it is a recognition that it's not all roseate currently. And following prior speakers, I'll end with my hustling final slide there. And thank you for your attention.
Thank you so much.